Assalamu alaikum. It is a great pleasure to be with you today. I will share with you some of my experience in two interesting subjects. The first one will be the congenital cataract. The congenital cataract is a vision-threatening situation, and it's affecting a fair number of our children in the country. One of the most important things in congenital cataract is to obtain a good surgical outcome to retain a good vision for these young patients to live with good vision through their life. We'll start today with congenital cataract. After that, we'll go through leukocoria. And the leukocoria, the most important subject in the leukocoria is retinoblastoma, because it's a life-threatening situation. For this reason, we are talking about two subjects: vision-threatening situation and life-threatening situation. And we'll go through the importance of this. As you know, congenital cataract could be isolated or associated with systemic conditions. Could be congenital, could be acquired, inherited, sporadic, unilateral, bilateral, partial or complete, or stable or progressive. It is present in very wide range of variation. If we look at this child present to the pediatric ophthalmology clinic with bilateral cloudy lens changes. This is a rhizomelic chondrodysplasia punctata. It's an autosomal recessive, paroxysmal metabolism disorder. The incidence is very low, but you may see one patient during your career in ophthalmology. They present with shortening of the proximal extremities, psychomotor retardation, cataract, early death. And the lab test will show elevated plasma phytanic acid. This patient, we didn't do any surgery for him, and the child passed away at the age of 13 months. For this reason, not all patients who present with congenital cataract should be submitted or subjected to surgical intervention. If you think the life expectancy is poor or the general medical status of the patient is poor, it's maybe not appropriate to push the child for surgery. Sometimes these kids may pass or may die during the surgical or the induction of anesthesia. 10% of all the vision loss in children worldwide is due to congenital cataract. There's about more than 200,000 children handicapped at the international level due to congenital cataract surgery or related complication or anterior segment dysgenesis. In bilateral cases, we could see that 50% of mutation in the gene that code for the lens clarity protein. Idiopathic could be seen in 30%, familial 60% of congenital cataract due to hereditary factors. Usually autosomal dominant, could be autosomal recessive, could be X-linked. Most of the autosomal dominant usually it's isolated to the lens changes, while the autosomal recessive sometimes they present with syndromic clinical features. Chromosomal could be seen in trisomy like Down syndrome, 13, chromosome number 13, 18, and other translocation, deletion, and duplication. Craniofacial syndromic presentation like Hillerman-Streiff, Rubinstein type B, and Smith-Lentis-Optis syndrome. We have experience with one of the patients who is a case of Hillerman-Streiff syndrome. Usually they present with resorb lens changes. They didn't come with swollen or total lens opacity. Most of the cases they present with resorb lenses. It's a membranous like cataract. This group of patients, sometimes they have multiple systemic abnormalities. Subjecting them to the anesthesia sometimes is risky. We have experience with one child. We were hesitant to put him for anesthesia. The anesthesiologist was resistant to put the patient, the pediatric ophthalmology pushing for the surgery, family pushing for the surgery. The patient was at age of 9 months, put to the surgery, passed away on the table at KKESH. For this reason, patient with syndromic presentation, you have two-way think. If you think the child is psychomotor or has intellectual deficiencies or general medical status, try not to push the patient for surgery till you are sure from the pediatrician or genetist that what's the life expectancy, what's the general medical status of the patient. You could see in these slides, this is the Hillerman syndrome, this is Rubinstein type, and this is Rubinstein type because you can see the thick and the thumb and also the toes is large for this group of patients. Sometimes they present with congenital cataract and glaucoma. This is a case of Smith-Lemeli-Optis syndrome. There are cases present with musculoskeletal disorder like Conradi-Hennerman syndrome or Albright syndrome. Myotonic dystrophy, they may present with congenital cataract at the same time and musculoskeletal disorders. There are two syndromes that you pay attention. Those present with renal abnormality or renal syndrome like Lowy syndrome and Alport syndrome. What is the incidence of Lowy syndrome or the ratio between male to female ratio and Lowy syndromes? Could anybody tell me? Usually, Lowy syndrome is exclusively affecting males. You will not find it in females. And you could see that they have, and then the first slide, you will see the posterior lentoconus, anterior lentoglobus, and also in this the lens changes. These are the renal syndromic presentation. And for this reason, if you have a patient with lens abnormality with this presentation, you have to look at the renal function and send the patient for a nephrologist to be sure that the patient, they could maintain the renal function, or at least to be aware that this child has going to have a renal function or renal failure in the future. Metabolic like galactosemia. Galactosemia is correctable disorder. Child may present with brain damage if there is no control is done at early could have brain damage, cataract, jaundice, liver hepatomegaly, kidneys damage, and it could be due to galactokinase deficiencies, or it could be due to galactonase 1 uric transferase deficiencies, depend on which enzyme is defected, or it could be both are affected. In these cases, the galactose, it will be accumulating, and patient will end it with lens changes that may indicate surgery. If the child is, if the patient diagnosis is made early, sometimes you could control and you restrict galactose from the diet, and in these cases you could maintain normal mentality and could maintain the clarity of the lens in the normal range in the future. Fabry's disease, and you could see that in Fabry's disease, you could see that this corneal changes, it's like all changes in the cornea, and it is one of the diseases that affect systemic finding. It's not only just the cornea. You could find in the iris and the lens and the cornea and the retina. There is ocular changes that could happen with Fabry's disease. Wilson disease, and could present with Kaiser-Fleischer ring or lens changes. Monocytosis or diabetes mellitus. All these those may affect the lens changes, and it may lead to congenital cataract. It's not uncommon to see patient or juvenile age with diabetes, especially I could see that there are a fair number of kids, they have diabetes and they may develop lens changes. If the diabetes is controlled, the lens changes may take longer time to be developed. There are acquired causes that may be not related to hereditary or genetics mutations, like intrauterine infection. Those patients may have a congenital cataract due to toxoplasmosis, rubella, cytomegalovirus, or varicella syndrome, or syphilis if the mother got the disease during the pregnancy. Iatrogenic corticosteroid could induce the cataract changes, and this could be seen in patients with either topical steroid or systemic. There are patients receive systemic steroids, especially pediatric, and they develop congenital cataract, and they developed glaucoma. And Dr. Sami Shahwan, I think he reported one of the cases that they develop glaucoma due to systemic corticosteroid treatment. Radiation is also it may cause lens changes, and we are seeing that in patients with retinal blastoma after radiotherapy. A patient may present with a color abnormality like aniridia, intersegment dysgenesis, and lens changes. Congenital cataract could be unilateral or could be bilateral, and presentation could be asymmetrical. Maybe a patient present with more advanced cataract in one eye more than the other eye. Could be idiopathic in 80% that you could not find a real cause because it is hereditary and without any systemic or syndromic presentation. There is about 10% of patients who present with congenital cataract. They may have ocular abnormalities like rhomicophthalma or or resistant fetal vasculature. A patient with retinal detachment may present to emergency with developmental cataract. The child, especially children, they may develop retinal detachment not detected by the family and become a chronic. Patient may present to the emergency with lens changes or total cataract. Trauma is known cause of congenital trauma is known cause of lens changes, and depending on the severity of the trauma, sometimes these cases may end with total subluxated of the lens or total lens changes. One of the important things in patient with retinal detachment, I become aware of some cases they present to the emergency. Patient received an ultrasound request done, seen by the resident or by the fellows. They consult the surgical retina on call. They told him that there is a patient with retinal detachment, total cataract. The surgical retina on call sometimes is overwhelmed with cases, not interested to see a case with poor prognosis, and then the case will be labeled as maybe poor prognosis or inoperable, and then the patient will be discharged. In these cases, you have to pay attention that not all, it's very rare to see pediatric age group with retinal detachment. It is very rare. With spontaneous retinal detachment, it's very rare. I can't recall cases except with testicular syndrome that they may present with retinal detachment. They may have trauma and develop retinal detachment is possible, but it's also, I will say, it is very rare. We're seeing a lot of trauma, and I'm sure the residents are seeing a lot of trauma, planted trauma in the ER. There could be commercial retina, but vitreous hemorrhage, but retinal detachment, it's not that common in pediatric age group as an adult. Patient with retinal detachment, once they present to the emergency, you have to think carefully. Is this real retinal detachment with lens changes, or there is other ocular pathology causing this problem? Yesterday we saw a patient who presented to the emergency. Sometimes, not in this hospital, patient received lens aspiration, glaucoma surgery, and there was some questionable finding in the iris by the B scan. Finally, the patient labeled as uncontrolled glaucoma, poor prognosis. Patient at 7 years presented with medulloepithelioma, extraocular extension. For this reason, maybe the reason for that lens changes is not the trauma, it is just there is an iris ciliary body mass causing these changes. For this reason, if you find a pediatric age group with unilateral, non-explainable cataract or lens changes, you have to think about other progress, maybe uveitis, maybe trauma, maybe tumor. Children abuse is not common in this country, but you may came across some children abuse, and maybe the child has received a trauma by relatives or parents or housemate. What is the lab work? Should we do a lab work for patients with congenital cataract? For straightforward and autosomal dominant or positive family history, if the father is known or mother, or there's another child with the same problem, and it is hereditary, it is autosomal dominant, and there is no syndromic finding, it's maybe not indicated to subject the child for routine investigation. If the patient first presented as a first case, you have to do some lab work. And we could see from the listed lab work here, we have to think about galactose metabolism. We should ask for urine-reducing substances, galactose 1-phosphate, uridyl-transferase, and galactokinase. We should ask for torch test and VDRL. For metabolic, if you think about metabolic diseases, you have to ask for urine amino acid test to rule out Lewis syndrome, serum calcium low also in the hypoparathyroidism, or phosphorus is high in hypoparathyroidism. Glucose levels also in high in patients with diabetes mellitus, and ferritin for cases in hyperferritinemia. This is the routine lab work that could be indicated. I noticed during our practice that it's not that common we are requesting lab test, but if you think that the patient family there's no negative family history, you have to request these lab tests. You may be the first one who will make the diagnosis for the family. Depend on the type of the lens changes. There is a different morphology that patient may present with congenital cataract. Spoke-like could be seen in Fabry syndrome and monocytosis. Corneal changes could be seen, and hepatosplenomegaly also could be present. Vacuoles could be seen in patients with diabetes mellitus, and increase in the blood sugar. Multicolor flicks could be seen in hypoparathyroidism and myotonic dystrophy, or it could be seen low serum calcium and level, and characterized by facial feature, tonic, and grip. Green sunflower could be seen in Wilson syndrome and Kaiser-Fisher ring. Thin disky form could be seen in Lewis syndrome and hypotonia in these patients with glaucoma. This is a group of slides that will show you the different type of presentation. This is just nuclear, and you could see the slit lamp photo. This is a nuclear cataract. These nuclear cataracts depend on the density. If they are dense, they are very effective. If they are not dense, and you could do refraction in these cases, sometimes not indicated to surgery in this patient. But most probably this type of lenses is progressive. And you need to observe the child closely. If the patient develops cataract in one eye, that means the patient progress in one eye, the other eye will progress at later times. You can see it in lamellar cataract also, like this patient. This is not dense, that like this one. You could see anterior and posterior lentoconus. We saw this slide in the previous slides. Posterior subcapsular opacities could be seen after steroid or trauma or radiation. Persistent primary membrane could be seen, like if this patient, usually once the patient present with membrane, usually it's bilateral. I can't recall that I saw a case unilateral with this presentation. All the cases I saw with persistent pupillary membrane is bilateral. I saw cases with persistent pupillary membrane with no lens changes and no need to do surgery. We were able to do refraction, and we provide the child with the glasses, and there's no indication to do surgery or to go on in the to the anterior chamber to remove these membranes, except if you are planning to do cataract surgery. Persistent fetal vasculature is not uncommon to be seen to patient present with lens changes. In cases of PFV, it's dependent on the severity. Some cases they may present with minimal, only just mitten dot at the back of the lens that may not indicate to do any surgery. If the opacity due to the PFV is small and you could refract the child, just observe the patient, give appropriate refraction, treat if there is any amblyopia, and if the lens changes become progressive, you could do surgery later. But if the patient presented with advanced persistent fetal vasculature, like this patient, or like this presentation, I mean this patient, you could see that in this case there is no way to do the surgery and implant IOL without scleral fixation. For this reason, you have two types of presentation. Patient may present with advanced persistent fetal vasculature that within the scope of pediatric ophthalmology to do. There are certain cases, no, it's not within the scope of pediatric ophthalmology to do. If you find that there is peripheral changes with the persistent fetal vasculature, it's preferable to move the case to the vitreoretinal surgeon, because if you do the surgery, you will end up with retinal detachment. And it will be labeled under your name as complication of this surgery. If there is anterior chamber is shallow, this means that this case should go from the beginning to the vitreoretinal surgeon. They could go through the bursa plana, they could dissect the tissue, they could attach the retina if there is a retinal detachment. If there is a tear, they could treat it at the same time. But for you as a pediatric ophthalmology, you could go up from anterior approach if it is simple, straightforward, persistent fetal vasculature. It's not uncommon. We just saw a patient maybe a few weeks ago. Patient was seen by one of our colleagues, presented to him. He was not aware exactly what's the problem. He thought it is just a case of trauma, and he decided to do the cataract surgery, and he, I think, couldn't dissect the tissue. Finally, he just did some lens aspiration, which he couldn't do, and then closed the corneal incision, referred the patient to KKESH. Patient presented with occlusive pupillae. Luckily, it's not a flat AC, but it's not uncommon to see patient after trial of removing persistent fetal vasculature in advanced cases, the iris will stick to the tissue, and then finally it will be occlusive pupillae, flat AC, secondary glaucoma. For this reason, if you face such cases, preferable, if you didn't have the surgical skill, it's preferable not to do the case, but refer it to somebody who have experience with these cases. We luckily able to dissect the persistent fetal vasculature, but it's not within the scope of the vitrector. It is not a vitrectomy tissue that you could cut it. Sometimes it is very tough, very stiff, very hard. You have to use intraocular scissor or venous scissor to cut it to small pieces, and when with the vitrector you could remove it totally. You will not be able to put any IOL in these cases in the sulcus nor in the bag, because there will be no remaining capsule. You will end it with either contact lens correction or aphakia with glasses or scleral fixed IOL. This is a case of patient with, you could see that this lens opacity is not indicated for surgery. This patient will progress with time. It's a blue dot type of cataract, and this is advanced form of patient. This is just, these cases is not indicated to surgery. For this reason, not all patients with lens opacities is candidate for surgery. I saw cases where they ended with complication more than if you decided to leave the patient without surgery. Patient may end with 20/60 vision, could manage at school. You could do the surgery at later age. It's not all patient with lens opacity there is indication for surgery. It's very important to know how to choose which patient should go for surgery. Is it because of the poor vision, strabismus, nystagmus? Sometimes you may have a patient with lens changes, not that significant, but he has a nystagmus due to another reason, not because of the deprivation of the vision. Okay, what is the routine things that we need to do for patient for congenital cataract? For patient as a newborn, we have to work a lab work within, when indicated. We have to check the vision, IOP, nystagmus, alignment, and eccentric fixation. Patient with eccentric fixation, if they present with eccentric fixation, that's mean the vision will not be better than 20/200. Once there's eccentric fixation, it's very rarely to regain any form of vision more than 20/200, because they're already, amblyopic, and it will be very difficult for you to improve the vision. You have to do slit lamp examination and be sure about the pressure is not, and do a scan to rule out any posterior ball abnormalities. You have to do AUA, corneal diameter. Why we have to pay attention about corneal diameter? If you decided to do a surgery and you find that the corneal diameter is small, sometimes these kids they have not only congenital cataract, they have microphthalmia at the same time. If the corneal diameter is small, it's preferable to do peripheral eye iridectomy. If you don't do PI, patient may end it with pupillary block glaucoma. It may not happen after 1 or 2 days, but maybe a few weeks, patient will present with secondary glaucoma. For this reason, it's preferable to do PI, regardless if you are putting IOL or without IOL. You have to know what's the axial length and to do IOL calculation. If there is indication for IOL insertion, it's preferable to do IOL calculation. If the child is not, you are not planning to do any IOL insertion, it's just limit your calculation with just your workup with just B-scan. We'll go through what's the appropriate timing for surgery. I put in my list what is I recommend. And who should do the surgery, intersegment or pediatric ophthalmology? يلا عطون مين بيصوت for pediatric مين بيصوت for intersegment. Okay. Up to what age? As a pediatric ophthalmology, you could do congenital cataracts. Till what age you are? I mean, we could manage. As a pediatric ophthalmologist, we are handling congenital cataract and more difficult than adult patient. Adult patient, they will come just for phaco, straightforward phaco surgery and IOL insertion. In pediatric, it's not as a straightforward like in adult patient. Most of cases ended with vitrectomy. For this reason, pediatric ophthalmologists, they have more skills to handle pediatric age group. Doesn't mean that the anterior segment, they didn't have the skills. No, they have the skills, but they maybe are not familiar with the finding that could be seen with pediatric ophthalmology, pediatric patient. For this reason, patient who is plus 7 years and plus could be managed easily by anterior segment as long as there is no congenital abnormalities and there is no indication to do vitrectomy. For the patient less than 7 years, it's preferable to do it by pediatric ophthalmology because they will need follow-up to be sure that the patient will not have secondary glaucoma, posterior capsular opacification, YAG laser capsulotomy, and any complication that could be encountered after surgery. For unilateral cases and bilateral cases, my recommendation to do the surgery is the same. There is no indication to put the patient for surgery just because he is 1 week of age, or you think that by this way that you will improve the vision. All the literature, all the researchers, they found that surgery within the first 2 months is safe. You didn't need to push the patient for surgery because he has congenital cataract and he is only 10 days of age. There is no indication for that. I saw cases where the patient taken from the neonatal intensive care unit, subjected to the surgery, ended with bilateral blindness. I saw cases where operated, at this age, and they put IOL insertion for 6 weeks old child ended with bilateral blindness. For this reason, the complication of insertion of IOL or surgery at this young age is not, far away from happening. For this reason, make sure that the child present to you, or you find a child in the neonatal screening, that there is a lens changes, there is no strong indication to push the patient for surgery or to refer him as an emergency case. Once the child has become 6 weeks, it's the appropriate time for doing surgery. For the first 6 months, it's okay to keep the child aphakic. After 6 months, it's preferable to discuss the case with the family. At 1 year of age, straightforward IOL insertion. From 6 months till 1 year, it's up to the physician and the social discussion with the family, and how could you convince the family that the IOL is better than keeping the patient as aphakic. All patients we did, and we kept them aphakic, and we correct them with contact lenses or glasses, ended with secondary IOL 3 pieces in the sulcus. They obtained the same vision like the others. The only debate is this group of patients, are they at risk of development of congenital glaucoma secondary to cataract surgery or no? Maybe there is a factor to increase the incidence of aphakic glaucoma if the IOL insertion is not done at early age group. For this reason, you could correct the patient with glasses, could correct him with contact lenses, or could correct him with an IOL insertion. For unilateral cases, it's okay to do it even the child is less than 6 months, as long as you have experience. Complication in patient with congenital cataract is not, easy to be managed. For this reason, it's preferable to have a good outcome and to maintain good vision for the child, because this child is going to grow up for school, for his life, for activities. We have patients who are now 20 years of age with 20/30, 20/20 vision, bilateral pseudophakia, because the surgery was good and the patient has no systemic problem, no secondary glaucoma. They ended with good outcome. Which type of IOL and where we should insert the IOL? It's preferable to put the IOL in the bag. But if you didn't have a bag or the bag is not good, it's preferable to go with 3 pieces and put it in the sulcus. Should we put 3 pieces or should we use 1 piece IOL? If you are planning to put it in the sulcus, go ahead with 3 pieces. If it's in the bag, it's preferable to use 1 piece. But at the same time, you could use 3 pieces in the bag. There will be no problem, as long as you have the surgical skill to do it. Inserting 1 piece in the sulcus is not recommended, because most of the time the haptics is thick. It will erode the iris, and few weeks or few months later, you will find that haptics in the anterior chamber. And stability will not be at your expectation, or it may subluxate it. It's not uncommon, or maybe you'll see children with anterior chamber IOL. I know that some of our colleagues, they did some cases where they put IOL in the AC. Most probably these patients will end with complication, corneal decompensation, secondary glaucoma, and finally you will find yourself you need to remove the IOL or to do also BKB. For this reason, anterior chamber IOL is contraindicated in pediatric age group. Iris fixed IOL. If the child is already aphakic and he's 18 or more, it's okay to think about a scleral fixed or iris, but nobody is doing any artisan lenses nowadays. Should you use multifocal or bifocal? I would like to go with monofocal for pediatric age group. It will be very difficult to predict what is the lens changes that, the axial changes that will happen in the future. For this reason, it's preferable to use just monofocal and correct the remaining with glasses. If you find that there's axial changes later after a few years and you need to do IOL exchange, you could do it safely. IOL exchange is not a big difficulties for pediatric surgeon to exchange the IOL. For this reason, should we use multifocal? Or if I use multifocal only if the child is 10 years and above. I did it in a few cases. But if the child still 3 years, 4 years, 6 years, it's preferable not to do any multifocal, and especially if it's bilateral surgery. One of the key important points is the capsulorhexis. If you succeeded in the capsulorhexis, you will be successful to put the IOL in the bag safely without any difficulties. And it's preferable to look at the other eye. The other eye, let's say that the patient sustained a trauma, ended with lens changes and cataract, and you are planning to do surgery for him. Okay, there is surgical slot tomorrow, patient present to the AR, you are in rush, you have surgical slot tomorrow and you are on call, you put the patient for IOL calculation, they did IOL calculation to the traumatic eye, you took the patient to the surgery, you did the surgery perfectly and you choose the appropriate IOL, insert it. Next day you will find that the patient doing very well, but he is strabismic or he has poor vision in the other eye. You didn't check the vision in the AR. Refraction revealed that he is myopic or hyperopic. For this reason, before unilateral surgery, any patient going for unilateral cataract surgery, you have to know what is the refraction in the other eye. If the patient is myopic, you have to think what's the power of the IOL that you need to put. If he is hyperopic, you have to think, because it will be very difficult for a child to be anosoconic, and anosoconia, you will find that you have emmetropic in one eye and the other eye +6 or -6 or more or less. Anterior vitrectomy to what age? Okay, up to 5. Anterior vitrectomy, once you do anterior vitrectomy, you will be 100% sure that the visual axis will be clear forever. As long as you did good capsulorhexis and posterior capsulotomy and good vitrectomy, visual axis will be clear forever. If you did no posterior capsulotomy, no vitrectomy, there is a big chance that this lens, posterior capsule, will opassify with time, and you need to take the child for YAG capsulotomy. Maybe the child has, it's difficult to be done as an outpatient, and you need to do it under GA. Not all the hospital or physician, they have the capability to do it in the OR. For this reason, my recommendation, up to 6, up to 8, it's okay, acceptable to do it. If the child is cooperative, plus between 6 and 8, it's preferable not to do it. But 6 years and below, I will do vitrectomy. Post-surgical, you could use antibiotic, steroid, or phenylephrine to prevent any membrane formation on the anterior surface of the lens. It's not uncommon to have some fibrin reaction after cataract surgery that may form and cause some membrane on the lens. For this reason, if you put the IOL in the back, it's preferable to keep the child on phenylephrine or dilating drops, mild dilating drops for a while, till you are sure that the eyes become quiet and no membrane is forming. If you put the IOL in the sulcus, you could put the patient also in the phenylephrine, but be sure that there is no iris capture by the optical part of the lens that could happen while the patient on the dilating drops. What is the IOL power that you will use? You may find that these tables and some of the textbook, between less than 6 months, you could put IOL with high power, 6 to up to 10 diopters, between 6 and 12, 4 to 6, 1 to 3, 4, plus 3. But for you, you have to be able to predict what is the appropriate IOL. Let's say that the child is 4 years, but his axial length is 24 or 25. Will this table work? It will not work. For this reason, you have to think about the patient age, his axial length, his K reading, type of cataract, family history. Is the parents wearing any glasses? Are they myopic or not myopic? And based on these factors, you have to predict what's the appropriate IOL power that need to be used for this patient. If the patient found, let's say that the child is axial length is only 19, and you decided to put plus, you will find that after surgery that he may need still plus 10 diopter more to be corrected with glasses. The highest power of IOL that's available is in the range of 30 to 35. If you need higher power in the 40s or 45, you have to request it specially, and may take 4 to 8 weeks to be available from the company. We are doing, rarely we are requesting, I can't recall any case that we requested high power IOL for pediatric age group. If you are doing surgery for a child who is 6 months and above, and you make the calculation, sometimes you may find the calculation of the power is 35. It's okay. Go with your estimation, check with axial length, look at the family history, and put the IOL power that you think it will work for this child. It's okay to correct him with the glasses. All the remaining diopters could be corrected with glasses safely. The axial changes will happen after a few years, and the patient may end it with appropriate refraction in the range of +4, -4 is acceptable. Complication of congenital cataract surgery is not uncommon, and one of the most common is the posterior capsular ossification. That could happen. Subluxation, you can see this is a patient with posterior capsulotomy and vitrectomy. You could see that their visual axis is clear. Well, in this case, I mean, you could see that there is posterior capsular ossification. If you did capsulotomy and vitrectomy, in these cases, when you do vitrectomy, you have to be very generous. I saw some of our resident and fellow, because lack of experience and they didn't follow the patient for a long time, they think that the limited anterior vitrectomy is enough. The vitreous will detach and it will start moving between the posterior pole and the capsule, and the lens epithelial will proliferate and will form another membrane, even if there is big capsulotomy in the posterior capsule. For this reason, when you do vitrectomy, you have to be very generous and try to remove most of the vitreous, especially in the anterior part, and to prevent any scaffolding of the lens epithelium on the surface of the movable vitreous. Patient may end with endophthalmitis, and you could see the hypopion. For this reason, it's not the incidence of endophthalmitis in pediatric age group. Do you think it is higher or less than adult? Abdullah. The factor is the same. The only thing that children, they have better healthy ocular surfaces than adults. Rarely you'll find them, they have blepharitis but you have to be very careful. If you decided to put the patient for surgery, be sure that he has no discharge, no redness, no nasolacrimal duct obstruction. It's not uncommon to have a patient with congenital cataract and nasolacrimal duct obstruction. If the child has nasolacrimal obstruction, what you will do? You have to do probing and stenting and wait. If there is indication for stent, okay, but if there is no indication for stent, just do limited to probing. Observe the child for a few weeks. If there is no more discharge, you could subject the child for surgery. Subluxation is not uncommon if the IOL is inserted in wrong position, or there is dialysis, or the haptics is broken. It's not uncommon that during the insertion the haptics may be kinked or broken, and the surgeon think that this haptics will work properly. No. If the haptics is kinked, you have to straighten it and to correct it. If it's broken, you have to change the IOL. You need to have appropriate follow-up, amblyopia treatment, and glasses is indicated to correct any remnant part of refraction. And you need to add for near. If the patient is pseudophakic, sometimes they need an add for the near. Okay, we are done with congenital cataract. We'll go with leukocoria, and we'll try to be fast because the time is running fast. This is a child who came from Somalia. It took from him 6 weeks to reach Riyadh. He lived in a small village in Somalia. From there, he was traveling with his father on a camel for about 200 kilometers. Then they ride a car. They came to Ethiopia. In Addis Ababa, they stayed for about 2 weeks till they got visa to get entry to Saudi Arabia. They arrived to Jeddah. From Jeddah, they stay with some relatives there. Anyway, it took from them 6 weeks to reach KKESH. At arrival, we find that there is bilateral advanced leukocoria, clinical investigation and clinical assessment. Ancillary test confirmed bilateral retinoblastoma advanced, ended with bilateral enucleation. He presented to me a few weeks ago, and his father telling me that he is now able to memorize the Holy Quran by heart, and he is almost now 13 years. And this is the story of some patient who may present to the leukocoria from far distance. If he didn't come to Riyadh, I didn't think he could survive if he had no treatment given to him. He's totally blind now, but still in good health and in good shape. Leukocoria, as you know, it means white pupil. You have to, once patient present to you in the emergency or in the clinic, you have to look at the family history, prenatal, postnatal history, trauma history, parents examination when indicated, outpatient examination plus examination under sedation or under GA if indicated. Vision assessment, intraocular pressure to rule out any secondary glaucoma, look at the iris if there is any iris neovascularization, nystagmus, strabismus, slit lamp examination and fundus examination if possible. P-scan to rule out any calcification. It could be seen in 85% or 86% of cases with calcification, but there is the 14% or 15% of patients may not have any calcification with P-scan if it's a retinoblastoma. CT scan versus MRI. Fine needle aspiration is not indicated for patient with possible malignant process. What are the main causes of leukocoria? Retinoblastoma, pseudo-retinoblastoma, congenital cataract. Congenital cataract, already we talk about it. We'll try to concentrate on retinoblastoma and pseudo-retinoblastoma causes. Classification, we could see that if V is not uncommon to be seen at emergency with maybe a white cataract or leukocoria changes. Retinal vasculature anomalies with lipid and translation like in Coats disease, toxic retinopathy, retinal dysplasia. Retinal dysplasia is not uncommon. You could see patient presented with bilateral retinal detachment at the age of 2 months of age. Those patients usually presented with shallow AC and some peripheral synechiae between the iris and the lens. Those patients who will present with shallow AC, exclusive, pupil is small, not responding to dilating drops, and there is funnel retinal detachment, most of these cases is due to retinal dysplasia and non-operable and no indication to do intervention. Inflammatory condition, trauma, neoplastic or proliferative lesions. 19% of cases due to persistent fetal vasculature is seen in leukocoria. And the rest you could see it listed like retinopathy prematurity, posterior cataract, coloboma, uveitis, larval granulomatosis. Congenital retinal falls, Coats disease, vitreous hemorrhage, retinal dysplasia. Could be unilateral, could be bilateral. Unilateral cases could be due to trauma, vitreous hemorrhage, persistent fetal vasculature, Coats, medullobethelioma, or larvae. While in bilateral cases, mostly due to retinopathy of prematurity, could be seen in Down syndrome, VHL angiomatosis, Neuri disease, incontinental pigmenti, or X-linked retinoschisis. How could we differentiate between persistent fetal vasculature and retinoblastoma? Usually there is negative family history in PFV. 90% of cases is unilateral. Usually there is microphthalmia, no or plus cataract with or without microphakia. Elongated cellular process could be seen at the periphery of the lens. Early retrolental mass and calcification is rare but could be seen. While in retinoblastoma it's totally different. These are two patients, one is with retinoblastoma and one with congenital cataract. This is bilateral retinoblastoma, ended with bilateral enucleation, presented to us in the clinic recently. He is already married and he has a baby who is 9 months. He didn't bring his child. We recommended the child for AUA and he will be for AUA in the next week. The second child, this one is just as we said, it's a rhizomal chondrodysplasia, died at the age of 13 months with bilateral congenital cataract. This is a group of patients. This is leukocoria. This is a child you could see. It's rare to see cataractous lens changes in retinoblastoma, but they may present with, especially if there is a necrotic or ischemic or infarction within the tumor, sometimes these patients may end with iris neovascularization and lens changes. This is a child. You could see synechiae is not common to be seen in patients with retinoblastoma, except if there is intraocular tumor infarction and inflammatory process happened. This is the B scan. You could see that the mass is visible by B scan. This is a child. You could see the pseudohypopia. And how could we differentiate between pseudohypopia and uveitis cases? Pseudohypopia usually could be seen in three situations. Could be seen with retinoblastoma, could be seen with medullobethelioma, could be seen with leukemia. None of these cases could develop synechiae or inflammatory process. Usually it is quite eye with just pseudohypopia. No synechiae in these cases. And no precipitated keratitis. And you could see this as just fluffy masses. Patients have some iris changes. There is a lymph node due to metastasis. This is just seeds in the vitreous. Seeds in the vitreous. This is the B scan. Could see this is the CT scan. Could see the calcium. This is cross section of the tumor. This is the histopathology finding in retinoblastoma, and this is one of the circulating malignant cell in the blood samples, optic nerve finding, and the pseudorosette. This is a child presented in 1991 with bilateral physical eyes. I presented this case maybe in previous presentation. I did the surgery and we were able to obtain more than 17 millimeter of the optic nerve. Cross section of the eye, you could see that the tumor is invading the optic nerve. She was subjected to 18 cycles of chemotherapy at KKESH Specialist Hospital. Finally, she was surviving. She joined Holy Quran School, belonged to Al-Rajhi Al-Bayan School. She is now memorizing the Holy Quran by heart. She gets married. She has 4 kids. 2 of her kids affected. The first kids were twin. We were able to examine them in the first weeks of life. We treated all the lesions. Both kids are affected. Both of them, they have 20/20 vision with multiple chorioretinal scar due to early management. The boy is normal and the third girl also is normal. This is a case of persistent fetal vasculature and usage, the ciliary process and blood vessels. And you can see by V scan the strand between the posterior pole and the fibrovascular tissue due to the lens resorption. This is a case of Coats disease, and you can see the blood vessel telangiectasia and the color. And this is the crystal from the subretinal fluid. It's not uncommon. You could see with the slit lamp, you could see the cholesterol crystal in the subretinal space. If there still it says clear fluid, but if it's advanced, it will not be possible. These are chorioretinal scar due to multiple factors: trauma, toxocara, and larva. This could be misdiagnosed as retinoblastoma if the physician is not familiar with retinoblastoma. This is a case of medullobethelioma and ciliary body mass. This is a case of abnormal optic nerve finding, morning glory, and could give you just a white reflex if you make a photography for the child. This is a group of B scan. The first one is normal. This one is vitreous hemorrhage, and this is a case of retinoblastoma. This is just persistent fetal vasculature. In this case, you could see there is a vitreous hemorrhage, but at the same time there is retinal detachment, and by A scan you could see that the reflectivity is up to 100%. This means that this is a retina. While in this case, this is just a vitreous hemorrhage, and this case is just retinopathy prematurity. Sometimes we request color Doppler imaging for patient. We did conduct a research regarding this modality of imaging, and we were able to see the circulation of the blood within the tumor. We noticed that some of these tumors may not have circulation if the optic nerve is invaded and occluded. You could see in this slide, the circulation is not normal. This is the case, and you could see the optic nerve, it's occluded by tumor. For this reason, with color Doppler, you could predict if the tumor is, if the optic nerve is invaded, but it will not change the management. This is color Doppler imaging. Before we end, I would like just to stress one of the important points. During the last year, we encountered maybe 4 cases mismanaged as a case of leukocoria by qualified consultant working either at KKESH or in the private. Patient treated as a case of endogenous fungal endophthalmitis, where the case is retinoblastoma, given antifungal injection. Finally, patient presented to us and they do the nucleation, turned out to be retinoblastoma, and it could be clinically diagnosed from the presentation of the patient. 2 cases managed recently by vitreoretina as a coats turned out to be retinoblastoma. 1 patient seen as non-operable retinal detachment ended with discharge from KKESH, present few months later with orbital extension, metastasis, and the child passed away. For this reason, if the patient is seen by somebody who is not paying much attention regarding retinoblastoma, the child could be lost. All children who present with a leukocoria or unexplained presentation, think carefully and seriously about retinoblastoma. Not all patients of coats are real coats, could be retinoblastoma. Not all patients with secondary glaucoma is just glaucoma, could be due to retinoblastoma. For this reason, I would like to stress these important points. I'm sure one of you in his future will see cases of retinoblastoma in the clinic, either in private or in the governmental hospital. And you may miss cases. But if you think about retinoblastoma as first diagnosis to be ruled out in patients with a leukocoria, then you could be safely safe and the child could be saved. Thank you very much. Before we conclude, I will give you just a few minutes if you have any questions. Fadli. Bilateral surgery is our norm to work at KKESH, especially if the child is medically healthy and there is no sign of infection, no sign of conjunctivitis. It's my routine to do bilateral surgery. As long as you change the surgical set, make appropriate preparation, and you are so sure about your equipment and about your sterilization department. To do the surgery at different dates is not contraindicated. To do the surgery, bilateral surgery at the same time is not contraindicated. Nowadays, even in Europe, they are doing adult patients bilateral surgery in the same day. For this reason, the incidence of endophthalmitis will not be increased by bilateral surgery. The only problem that if your instrument is not clean, you may end up with bilateral endophthalmitis, which will be a disaster for you and for your patient. But for pediatric, even congenital cataract, congenital glaucoma, we're doing surgery for both eyes in the same setting. Halas? Yeah, thank you very much.
want to introduce me? Okay, because I don't have an intro. Diego said,
If you want, if you don't know, it's up to you.
It's up to you. You want to introduce?
I can introduce you.
Okay,
You're
sure.
a nice person.
Sure. Oh, thank you.
Start now?
Yeah. Well, I need to find it. Hold on. I have. You can speak here if you want, or there. كيف okay. AAO highlights. Yes.
Assalamu alaikum. Good afternoon, everybody.
فيما بعد مو دحين. فيما بعد.
Today, Dr. Savsan Novelati is going to talk about the AAO highlights. All of us know Dr. Novelati for her hard work and dedicated work. She's a great clinician and also a very talented teacher. So I would like to let the floor for Dr. Savsan to talk about the highlights of the meeting. Okay, thank you.
Okay. Thank you very much for the introduction, Dr. Taskentuna. That was very kind of you. لو سمحت لو ممكن تنزل لي هذا شوي please. نزل لي شوي. Okay, thanks. شكرا لك. Yeah. Okay, I think we will start, and the lecture actually takes place here and not outside. So thank you for attending this special grand rounds on the AAO highlights. As every year we go to the AAO, we always learn something new, and one of the highlights, of course, of the AAO is also that we meet with ex colleagues from who have worked at KKESH before, so it's always a very nice place to visit. In this year, it was very nice for me to actually go to San Francisco because that's when one of my daughters lives. So it was زي ما نقولوا عصفورين بحجر. So without further ado, I would like to start, and I would like to tell you that some of the slides, the photos in these presentations, and some even of the slides that I had taken pictures of do belong to the original speaker. So I just want to, write a disclaimer here that I do not own the information presented here, although I have edited some of it, but I do not own any of it, and there's no copyright claims. So what's new in at least the realm of retina specialty? Well, there's a new maculopathy that everybody should recognize. And we have not been recognizing it because nobody actually thought about it and knew about it until these people from Emory came out thinking about it and publishing it. So this is a maculopathy that they're calling pentosane polysulfate maculopathy. And as you can recognize, this is a drug. And this drug is a macromolecule that resembles the glycosaminoglycans, and it's been given for a long time for people who have interstitial cystitis to decrease the burning and the urgency and all the problems that come with it. And people generally take it for a very long time, for years and years, a little bit like hydroxychloroquine. It's a chronic medication. So in the USA, there are more than 1 million people affected by interstitial cystitis, and so this is a very common used drug that's called Elmiron. Okay, and what Elmiron, after a while, gives is a pigmentary retinopathy in the central part of the macula that very much looks like, pattern dystrophy or AMD. So this was unrecognized. What the people from Emory did is that they found a few cases, and with just the simple history taking and knowing about, what medications are you taking, it came out like several people were taking this medication. So this kind of, alerted them that there could be something in this medication. So what they did is that they retrospectively, in their institution, reviewed all the cases that had interstitial cystitis, 219 patients, and they found that 80 patients were on this drug, and 14 of them had maculopathy, and 139 had no prior drug, and none of them had maculopathy. So they went to the insurance claims, and they said to themselves, okay, let's look at all the patients have had this pentazan polysulfate prescribed for them, and they found about 45,769 patients, and then they said, okay, let's look at how many have had it for 5 years, and about 3,000, and how many were exposed for up to 7 years, and it was about 1,600 cases. And they then looked at, okay, what is the possibility? Let's look at these people and let's see if they had any claims besides the cystitis, about any retinal disease, maculopathy. And it turns out that people who were on this drug, particularly those who had 7 years of intake of this drug, had a very, very high ratio and odds. The odds of the diagnosis of macular disease was quite high and very highly significant, that this maculopathy would appear within 7 years. So what does this look like? It looks, after a while, a little bit like this. So in their study, they found out that the median intake duration was about 14 years for patients, and the median onset of symptoms was about 5 years. But the symptoms actually could appear by 1 year and up to 9 years. And although the visual acuity, the central visual acuity was good, relatively good, it could actually go up to 2400, but relatively good. And that is because usually the central part of the fovea in all macular diseases, subhanAllah, they don't get affected until the very late stages of the disease. When you get atrophy, even in dystrophies, when we get atrophy, the atrophy kind of starts around the central part of the fovea, and at the end, it kind of closes in on the fovea. So people like this can definitely have 20/25 vision, but you'd imagine that, the visual symptoms are very, very, uncomfortable for the patient, with the blurry vision and prolonged dark adaptation and difficulty reading and so forth. So here what it looks like clinically, and it could be very subtle. You can see a yellowish background with some pigmentary clumps, something that really looks like AMD, honestly, or pattern dystrophy. With time, geographic atrophy does develop, and sometimes you can see these yellow spots, throughout the fundus. And this is what it looks like on an autofluorescence, which is very, very, very nice modality that brings out all these pathological changes. And what you can see is those densely packed hyper and hypopigmentary spots, usually in the macula, and sometimes, especially with progression, you can have progression with geographic atrophy. So you have these large patches of hypoautofluorescence, and sometimes, as we said, the disease can be diffuse. So keep this in mind. So here are some examples of cases that they have seen. And you can see basically the pattern repeats itself, and on the autofluorescence you can see both the hyper and hypopigmentary spots, and the diffuse disease in some cases, and the geographic atrophy, as you can see here. All right. The problem with this is, just like hydroxychloroquine, is that it's a continuous disease. And sometimes it happens very, very fast after the onset. You start with something like at 2015, a few spots here, and then, a year later, it's much, much worse. And within 3 years, it's actually much, much worse. And the problem also, just like hydroxychloroquine, that it continues even after drug cessation. This is the same patient, at 8 months, and after 11 months, you can see that there is increase in the geographic atrophy, and increase in the number of spots that have started to become atrophic after they have been diseased. So what is the take-home message of this highlight? Is that now we know, when we look at a patient who seems to have maybe not the right age for AMD, or the patient seems to have macular dystrophy, I think it behoves on us to really do a very, very good history of medication intake. Not just are you taking hydroxychloroquine, or are you taking some of the other drugs that affect the macula, like tamoxifen and so forth, but also remember this. Do you have cystitis? Do you take any chronic medication for cystitis? Okay? And believe it or not, although this has been published, until now, the leaflet of the drug, and even on the website, if you look up pentazan polysulfate, you'll see all the side effects, and until now, it doesn't say that, this actually can give, macular side effects and visual side effects. So that has to be addressed by the pharmaceutical company. So now we do have a new role. We need to identify this disease, and we need to get a detailed medication history as well. If somebody is taking it, So we need to discuss this with the patient. We need to do baseline color fundus photos, fundus autofluorescence, and check about the duration of treatment. We should be doing a repeat screening if somebody's going to be taking at least at 5 years. I would say even before that, and screen patients who are at higher risk much more frequently. Like if they already have a macular disease, another macular disease, or they have renal or hepatic problems, or they're smokers. And if anybody is diagnosed, the best option would be to drug cessation, but knowing that it can continue. So very interesting. Another really interesting thing happened in the AAO is that there is a new thing for AMD, for the treatment of wet AMD. You know that for wet AMD, all what we do nowadays is give injections, right? Injections of anti-VEGF. And the problem with the injections is that in the clinical trials, when injections are given on a monthly basis or on a very strict protocol, the results are really nice. As nice as they could be, but when in the real life, people cannot always come on a monthly basis, and sometimes they cannot afford this treatment, so the results are not as good in the real world. And so the approaches have been either to try to get drugs that last longer, okay, or do or insert some kind of a reservoir, like Novartis is coming up with this reservoir that you insert surgically, and you fill the reservoir every few months, or that you get intravitreal depot formulations that can stay longer. But what's really new is now there seems to be subretinal gene therapy, and believe it or not, an intravitreal gene therapy for AMD. So let's look at the subretinal gene therapy for neovascular AMD, and this was presented by Dr. Jeff Hayer. And actually, these are preliminary results. These are not like phase 3 trials. This is a phase 1 and a 2A. Phase 1 trials are usually conducted on a small number of patients, and they primarily address, is it safe? Phase 2, they usually primarily address, is it safe and is it efficacious? So there have been a number of patients that have been treated. And what this subretinal gene therapy is using is a new vector. It's an adenovirus-associated virus vector, number 8, and that is going to deliver a subretinal anti-VEGF antibody fragment. And this antibody is going to insert itself into the cell, and it's going to make the cell produce a protein that has anti-VEGF properties, okay? So the patients, now, it's very important to know that patients were not selected haphazardly. Patients who were selected to undergo this trial were patients who had wet AMD and who were very difficult to maintain off aflibercept or off anti-VEGF treatment. These are people who required to have the anti-VEGF treatment regularly. And on average, these are people who required at least 9 injections per year, okay? So people who were responding, but they needed that continuous monthly or 6-weekly anti-VEGF treatment. So what this trial is that they had enrolled so far 42 patients, okay, in 5 escalating doses. That means a number of patients, maybe 6 patients had very small doses, and then another 6 had a higher dose, and another cohort with cohort number 3 had a little bit more patients and a higher dose, and so forth. So you have 5 groups of patients with escalating doses, and what they did is that these patients had aflibercept or another anti-VEGF, I think it was aflibercept in this case, and they were then given an subretinal, so a surgical procedure, subretinal injection of this RGX-314, and then they were followed, and the protocol allowed that, well, if they develop subretinal blood or deterioration of vision or increase in the CNV size or subretinal fluid, then they can get back to their anti-VEGF treatment. Okay, and so far there is a 1.5-year result for the cohort number 3. Okay, the ones who had received the middle dose right there, and 6 months results, which were presented 2 weeks ago at the AAO for the patients who in cohort number 4 and cohort number 5 who had higher doses. And what Jeff Hayer said is that this was really this product was actually very well tolerated, and there were no drug-related side effects or major systemic side effects. Now, there were 2 patients who had surgical complications, but it wasn't related to the drug itself. And they could not clinically determine any immune response in the body itself. And basically, what they did is that they injected the subretinal RGX, and then they continued to test how much protein. They sampled the aqueous to see how much protein, anti-VEGF protein, was observed, was present in the eye. And the cohort number 3, cohort number 5 had the highest protein samples. So what were the results in terms of efficacy? All right. Now, 3 of the 6 patients, remind you that these are patients who required frequent anti-VEGF injections. 3 of the 6 patients in cohort 3 that we have, that they have 1.5 year data on, did not require any more injections. This is amazing. Okay. And in cohort number 4, which had a slightly higher dose, 42, that 5 patients out of the 12 were injection-free at 6 months. Not a long time, but injection-free. And in cohort number 5, 9 patients, 75%, 9 patients out of the 12 were injection-free at 6 months with stable and visual outcome. And here's an example. Now, this is a case number A who received aflibercept basically every month. Right? May, June, July, you can see that there is persistent fluid, all the time. And he gets it RGX 14. And what happens is that this patient received 13 injections in the year prior to treatment, and then gets this subretinal gene therapy here. And basically, at the end of the 5 months period to 6 months period, he is, absolutely dry. So, maybe too good to be true. We'll know. We'll see how it is. But it was, I think, fascinating. There's another case that he presented as well. This is a patient who has received 8 injections in the year prior to the aflibercept injection. Then the minute he gets she gets the RGX 314 drug, very, very quickly on, the fluid kind of disappears. Maybe there's a little bit of fluid here, but actually you don't see much fluid right there. So basically, what is the plan for this group of people? Is these scientists is that they're going to now move to recruit more numbers by the end of the year, and they're going to actually evaluate the efficacy of this in diabetic retinopathy, not just in AMD. So soon, maybe we will not have any work to do as medical retina specialists, and they're going to actually think about putting or expanding this same drug to deliver it into the suprachoroidal space instead of subretinally. Now, what was the long-term effect of this? Well, actually, we really don't know, but we know that from cohort 3, the levels of protein that was secreted by this gene was quite high and reasonable, and they did not require any further injections. Were there serum antibodies that neutralized the protein? They did not see any correlation between the response in the patients and the level of antibodies, and nobody required really immunosuppression for that. Now, and there was this patient that they discussed that they did not respond. Actually, required additional treatment, and Jeff Hayer said that actually he did have high protein levels, but he still required multiple anti-VEGF injections. So, what is the best candidate in the future, if this thing gets approved, is that people who demonstrate a good response to anti-VEGF therapy and require frequent injections are the best candidates to prevent or to decrease the need for many injections. Okay, and now the exciting one is the 24-week results of the study of intravitreal gene therapy for neovascular AMD, which is called the OPTIC trial and presented by KKESH. Now, the product that they're using is called ADVM22, and this is an advanced intravitreal gene therapy that is designed for a long-term VEGF suppression by the intrinsic production in the eye of aflibercept. And this vector, this is a new vector. You can see this is AAV7M8 vector. This is a specifically engineered vector designed for intravitreal injection, and that enables a robust production of aflibercept, in the eye that would be delivered to the retina. So you can see here from the schematic here that this is the capsid of the virus, okay, and you add a promoter, and basically everything is integrated together, and this will go into the cell, change the RNA, and aflibercept is produced. So in primates, human studies, a single intravitreal injection demonstrated a robust and long-term stable expression of aflibercept up to 30 months in the therapeutic level, and that the levels were equal to monthly injections of aflibercept. So the OPTIC trial is a 2-year study of a single in-office intravitreal injection of ADVM-22 in previously treated wet AMD patients. And they only had 6 patients, but they wanted to present that. So what happens here, that enrolled patients, again, same scenario. There were patients who were tested before, who he needed frequent anti-VEGF injections. Okay, so basically they received aflibercept before that, and before they were enrolled in the trial, they had to had received the aflibercept between 7 and 14 days. Okay, and then the injection of the AVM-22 was given on 1 day. Okay, and the prophylactic steroids were given orally. Just before and just after the injection, and then basically the patients were observed, and if they needed rescue treatment with regular aflibercept, they were given that, okay, if criteria were met. And although we have only 6 patients, but the investigators claim that it was safe and well tolerated throughout 24 weeks. But if you look very carefully, you'll see that nevertheless, I would say a quarter of the patient, or maybe not a quarter, actually more than a quarter, but there were several adverse inflammatory events that had happened. And we know that aflibercept also sometimes gives, inflammation, but it seems like this product gives a little bit more inflammation. However, they claim that it was not, a bad inflammation, and that there was never any vasculitis or retinitis or choroiditis, and there was no worsening of the events, no worsening of the new events observed, and that with time that this inflammation kind of decreased. So this remains to be seen. The best visual acuity results were maintained, and the OCT decrease and the OCT thickness was maintained throughout the 6 months without need for rescue injection. So it's fascinating. Again, they presented a few cases. This is a patient who had received 109 injections and had, in the last 8 months, 6 injections, okay, of aflibercept. And he is showing that there was some kind of a resistance, that always a recurrence of the subretinal fluid after, the 4 weeks has passed. And then here, the patient receives an intravitreal aflibercept injection, then on day 1 gets the ADVM-22, and then you start to see that there is a decrease in this subretinal fluid by week 24. So there was no rescue treatment in this patient at all at the week 24. We don't know in the future, but right now this seems very interesting. Again, here they're showing us the 6 patients, and you can see one by one how all of them, they kind of decreased their subretinal fluid, with some of them, getting better vision, some of them not improving vision, but nevertheless, no subretinal fluid was, observed, except here I would say that probably I would not consider that this was an improvement at all. All right? So, well tolerated, the inflammation was generally mild, and patients maintained vision, and there was zero rescue treatment for any subject. So, and the conclusion was that this potentially offers a transformative way to reduce the treatment burden and improve the retinal anatomy in AMD. And they are going to enroll more patients, and they're going to think about expanding this into the diabetic retinopathy treatment management. Okay. Do we have new anti-VEGFs or new models, new treatment modalities for AMD? Yes, we do. Something that may come up next year, as soon as next year. One of them is called abicipar. So the trials that looked into this were phase 3 trials, so randomized trials in patients on a larger scale. The trials were called Cedar and Sequoia, which are, as you know, they're 2 big, beautiful trees. This was presented by Rahul Kunana. And basically, you know about the Avastin and the ranibizumab and the aflibercept. This is the equivalent of aflibercept that's present in China, combercept. This is brolucizumab, which is a very small single-chain antibody fragment that has been approved in the United States and is supposed to act for at least 3 months. We'll see. And now the apikepar is a tiny, tiny, tiny molecule. It's called a DARPin, okay? It's a smaller molecule weight. That has a 94 times binding affinity and longer than the half-life of ranibizumab, so it will last much, much longer. I'm not going to bore you with this. Basically, the CEDAR and the Sequoia trials compared 2 different doses of, or actually 2 different treatment interval for abicipar, ones that were given an injection of abicipar at 8 weeks, every 8 weeks, and one every 12 weeks, comparing it, unfortunately, not to aflibercept, which we know is a little bit more powerful, but to only ranibizumab every 4 weeks. And what we can say in a nutshell, that it met its endpoint and bringing basically visual acuity similar to ranibizumab and OCT results similar to ranibizumab. Although if you look at the ranibizumab, there is a stable decrease in the OCT, while in the apikepar we see something like we see sometimes in aflibercept, where the retinal thickness increases and decreases every time that you give an injection. But it seems like they're going to be getting the FDA approval. They're working on getting the FDA approval for this. Again, I just want to tell you that this has been noted to have, in the early stages of the treatment, higher incidence of inflammation, but it seems like this subsides with time. Another interesting one, and I'm not going to dwell on it because I myself don't understand it completely, is another molecule that's called KSI-301, which is promising safety, efficacy, and durability. So that's interesting, and I think this is interesting for everything. What is new in endophthalmitis? Well, what we know is that the only proven successful prophylaxis for endophthalmitis post-intravitreal injections is povidone iodine. We know that. We know that by giving antibiotics, it really, it hasn't proven to be efficacious in eradicating or preventing endophthalmitis. But povidone iodine, everybody agrees that that's the way to go. And there were suggestions that you should put your gloves, you should keep your mouth shut, so that the germs don't come into the eye and so forth. But basically, no other part of the injection besides the povidone iodine was found to affect the endophthalmitis rate. So Tariq Hassan in Royal Oaks decided with his group to look at the predictors of post-injection endophthalmitis. How did they do that? Is they retrospectively reviewed all cases of endophthalmitis within the past 39 months, that all cases of endophthalmitis that happened after an intravitreal injection within the 15 days from the injection. Which endophthalmitis cases? The cases that were performed by 15 of their group, of their surgeons, of their vitreoretinal people, who already were, established enough and had a very decent and reproducible, stable protocol. As you know, each one of us has a way of doing injections, and we always tend to do the same routine, with every injection. So they looked at the stable routines, which are the people who have very stable routines. They identified 15 injecting physicians, and they looked at what is it that they do, okay? Who got endophthalmitis, and what is it that they do? Is there anything that we can come up with besides the povidone iodine, to see whether something else can increase or decrease the likelihood of endophthalmitis. So, and they used basically everybody. All kinds of patients who were subjected to injections were included. That is AMD patients, DME, CRVO, what have you, and all kinds of injections. So there was not necessarily reduced to just Avastin or aflibercept. So they used that. They looked at, okay, who uses lit speculum? Okay, you'll notice here that there are always 15 numbers. You add them together, makes 15. So we used who uses lit speculum, who uses gloves. Yes, did 13. No, I found that was interesting that despite that in the States that, in this institution, at least the majority do not use gloves for intravitreal injections. I find that kind of interesting. The strict no policy talking, who abides with this, who really, doesn't talk and doesn't let the, patient talk during the procedure. As you know, we tell people not to talk so that, the germs don't come out of the mouth and go into the sphere around the area of the eye. And they looked at the strength of the povidone iodine. Those who used tetracaine gel, hypromellose, this is a thick anesthetic, and those who used lidocaine gel, subconjunctival lidocaine, those who did the conjunctival displacement on a pledget or not, whether people have been using a topical antibiotic drop at the time of the injection. I also found that interesting because we know that topical antibiotics really don't make much difference. They just increase the resistance. Despite that, I found that half of the people were still using an antibiotic drop. That was interesting for me. Choice of medication, whether that made any difference. The injection site, I always tend to do my injections superiorly because I always thought, well, superiorly, I think there's a less chance of infection than if I do it inferiorly based on what I know from bleb related endophthalmitis. So I tend to always go up. And so they looked at superior versus inferior, and all of these doctors had they actually gave a povidone iodine drop just before the injection. And I think all the residents here and the fellows who give injections know that just before we do an injection, we give one drop on the conjunctiva where we're going to inject, just to be comfortable, and then we go ahead and we insert the needle. So all of them gave that, okay? That was a consistent procedure. So what was the key finding? Well, that thick topical lidocaine gel and viscous tetracaine hypromellose drops have a much higher likelihood of endophthalmitis, even if povidone iodine was given as the last step before injection. The odd ratio of getting endophthalmitis if lidocaine gel was used was it increased the risk by more than 11 times. With the other gel, with the thick drop, again, more than 4 times. And that is probably because the viscous material prevents the povidone from coming into contact with the conjunctiva and reaching the conjunctiva. So the reason we give these anesthetics is to decrease the pain, because if you give povidone iodine, it actually is very irritating to the eye. So most people tend to put they do the gel first and then they prep, right? If you do that, the prep is not good enough because the povidone iodine does not actually reach the conjunctiva, and then there is a higher risk of endophthalmitis. So one way of maybe getting rid of this problem is putting just a drop of tetracaine first, then doing a very good drop prep, inserting povidone iodine, and then if you want to may be extra careful with the patient not having any pain, put some gel. But I would say I would go with what they have recommended, is that to stop using the gel altogether. I personally have never used it. I know that a lot of people have not used it, but that some people were still continue to use the gel. So if anybody in the injection clinic is using the gel, this is a very busy clinic where errors can happen. Please refrain from using gel at all if possible. Another thing that we were alerted to at the subspecialty meeting is retinal artery occlusion. What do we do? Okay. Well, we all know that when it's a devastating thing to see in the ER when a patient, young or old, comes in with a acute severe loss of vision. And yet, generally, when the patient is young, we go through a series of workup, and I really suggest that the residents and the fellows picture this, since you all have your phones. So this is what you need to do in a patient who has a CRVO. All right. So we do a systemic workup, and we also have to think about systemic vasculitis in these young patients, and sickling, particularly in this country, sickle disease. If the patient is over 50, or I would say even over 60, then giant cell arteritis, you always have to put that in mind. But even if you do that, and then you start saying, okay, I'm going to do a massage or AC parentheses or give Diamox or what have you to do, try to help the patient, then what do you do? What do you do exactly? What happens? In most of the cases, we say to the patient, well, I'm sorry, we cannot do much. Let's investigate your heart, and your carotids, and let's go. All right? And actually, conservative treatment there is no evidence that conservative treatment is better than no treatment. If you just leave in a CRO, the natural history of CRO, based on this study that came out in 2017 in the Neurology Journal, About 18% recover to, visual acuity between 2000 to 2200. And with conservative therapy, in which we, give Diamox and do massage and so forth, actually less than that recover. So there is absolutely no proof that our measures work. And the thrombolytics are also very controversial. And if you give TPA before 4 hours, maybe it will work in 50% of cases, but you know that we see very few people within 4 hours from the attack. Intra-arterial local fibrinolysis also showed no definitive benefit based on this great study. But the presenter here wanted to remind us of some recent literature that we may not be aware of, because a lot of it comes into the neurology literature, is that a retinal arterial occlusion is actually a part of the definition of a stroke. Okay? So a stroke is an episode of neurological dysfunction caused by focal, cerebral, spinal, or retinal infarction. So if a person with a central retinal artery or ophthalmic arterial occlusion is actually having a stroke, right? Because it's part of the definition. And this was pointed out in June 2014 at the AGO by Valérie Bius. That showed that there was a high association and correlation between developing a stroke in people who have central retinal artery occlusion. In June 2014, based on 33 eyes, they looked at the co-occurrence of CRAO with an acute ischemic stroke, and they found that among the patients who had a central retinal artery occlusion, when they were imaged, 24% had an acute CNS infarction that we don't know about, and 38 of these had absolutely no symptoms. Again, similarly, in an article that came about a year later, same thing, 24% of people who had central retinal artery occlusion had concomitant acute CNS infarction, and 90% of them had no sign and no symptom, okay? And then in ophthalmology in 2015, basically this huge article that came out that actually there is a peak risk of an acute stroke within 7 days from a central retinal occlusion, and there's still a high risk within 30 days. So 10% of patients with CRAO, 10% are going to have probably an MI or a stroke within a week. So if it didn't already happen. So what was the recommendation is that we have to follow stroke guidelines by doing what we call a prioritized urgency. If a patient comes in within 24 hours, we should not be wasting time. The patient has to go to a general emergency room or emergency department and be seen by a stroke team, where carotids have to be performed on the spot, a carotid examination on the spot, and a Holter and an MRI or an echo have to be done very, very rapidly, okay? If the patient comes in between 24 hours and 14 days, they should go to a a TIA clinic. And if it's on a weekend, then go to the emergency department, again, for exploration of the carotids and MRI. And if it's chronic, that is more than 14 days, then just a TIA clinic to get a carotid examination done, which is what we do. But what we should do for those coming to the emergency room at night is we need to actually channel them very quickly to an emergency department that knows how to deal with, or a TIA clinic that knows how to deal with it. For us, we have to make up keep on following these patients, because some of them develop neovascularization of the angle and the iris, and leading to glaucoma. So that is where our role is, okay? So what we need to do, and I think it's important that we at KKESH and maybe at the university, but I guess the university is already self-served, but we have to start developing a working relationship with the closest stroke center to help these patients, because they've already lost their eye, and it would be shame that if they also had a stroke that we didn't know about. Okay. Let's breathe. Another highlight. How am I doing in terms of time? Is that okay? Am I doing? All right. Okay. Just let me know. Yeah. Let me know. I have a few things that are interesting, yeah. Okay. All right. So. Another thing that I learned was kind of interesting, I thought, was a randomized study to look at the efficacy of the spironolactone, which is eplerenone, use in central serous chorioretinopathy, okay, presented by somebody called Andrew Lottery. And here basically the aim of this study was to compare the efficacy and the safety of eplerenone versus placebo in the treatment of chronic CSR that's CSR that has been present for more than 4 months. And the patients were followed for 12 months. This was a phase 3 trial. It was masked. The 114 patients were enrolled, and 1 eye per patient was enrolled. The eplerenone dose was 25 milligrams QD for 1 week, and then increased to 50 milligrams in the following weeks. And then basically they looked at, discontinued, and they looked at the results at 1 year. And as you know, the spironolactone or the anti-aldosterone drugs were kind of popularized a few years ago by Professor Francine Béat-Cohen. She works in France, and she did some animal studies and studies on patients that showed efficacy and the ability to reverse the central serous exudation by decreasing the cortisol tension in the choroid. So people were encouraged to use this, and personally I have used it. Some of our colleagues here have used it. People all over the world have used eplerenone, and in here we don't have eplerenone, so we're actually using aldactone, which is, works also well. And works not in every case, but it works in about 50% of time. So when we didn't have PDT, for instance, we just give aldactone, and 50% of the time we do actually see a response. And sometimes we see a response, and then when the patient stops taking it, the CSR recurs, and we give the aldactone back, and the response happens. So I know that the response is real, okay, but is it really better? Because CSCR also has, recurrences and bouts of getting better. Well, the conclusion was very surprising, that eplerenone was not superior to placebo in treating central CSCR, and then the recommendation of the study was it should not be used for the treatment of CSCR. So I'll be very curious to see if people in the audience, esteemed audience, would like to discuss this after we finish our talks. This is important, and this is going to, I think, change the way we think of the grading of diabetic retinopathy. And this is not an entirely new concept. This is a concept that people started to talk about a year and a half ago, okay? And that is the use of wide field imaging and the detection of predominantly peripheral lesions in diabetic retinopathy. And the question here that was posed is, does the additional visibility, the visibility of the additional areas in the periphery beyond the EDTRS fields, these are the 7 standard fields of the EDTRS, classic fields that we've been using for 40 years. But now that we have wide field imaging, we are able to see stuff and changes outside these fields. And the question was, do these changes matter? Does it mean anything if a person has or has not these peripheral changes? Does it change the grading of the retinopathy? Does it change the risk of progression of the retinopathy? What do we do about them? Okay, so what is the pure definition of predominantly peripheral lesion? What we call PPL is that when you have more lesions, diabetic retinopathy lesions, and there are hemorrhages and microaneurysms. That's what the lesions are: macroaneurysms and hemorrhages. So if you have more of them outside the EDTRS than inside the field of the EDTRS, then this retinopathy is considered a predominantly peripheral, a retinopathy with a predominantly peripheral lesions, okay? And right now this is being studied in the DRCRNet protocol AA, and it's an ongoing study. We don't have the results yet, but so far they intend to include 766 eyes of 386 patients, and the study is supposed to go for about 4 years. So basically, the bottom line, if you only grade the diabetic retinopathy, and this is being used a lot in telemedicine, by the way, if you only grade it based on what you see in the EDTRS field, then there is, of course, a progression with time, and the chances of progression with time from no or mild NPDR to getting 2 steps or more of diabetic retinopathy will be much higher if patients had predominantly peripheral lesions. Okay, it will be 3.5 times higher, and the onset of PDR is also 4 times higher than if the patients did not have predominantly peripheral lesions. And they, in the study, they're looking at what happens, what is the odd risk ratio of getting into a 2-step increase of diabetic retinopathy or getting into PDR in patients that have mild NPDR. Well, it turns out that if you see those lesions and you look carefully, then the chances are that there is a much, much higher risk of getting PDR soon at 4 years if you notice a lot of these lesions. And the risk increases with the number of peripheral lesions. The more you have lesions in the periphery, the faster the retinopathy develops, basically. So the retinal periphery holds substantial information that may permit better assessment of retinopathy progression risk. Okay, retinal periphery people, residents and fellows and retina and in other specialties, I urge you to use your indirect, because I see a lot of people still examining retina with just a 78 lens or a 90 lens. Use your indirect and look at the periphery, because the periphery has a lot of information and it tells you whether somebody is going to evolve in a faster way than somebody who doesn't have those lesions, all right? And this is going to be very important because it's pertinent to clinical care, all right? And pertinent to clinical trial design, and also pertinent to telemedicine. Usually we don't see these changes in the periphery, so it's important when we want to evaluate what is the risk of progression, when should I see this patient next. It is important to know the whole picture and not just concentrate on the EDTRS field, okay? So we must evaluate the retinal periphery in eyes with mild or no or moderate NPDR. The retinal periphery has a lot of information, and it may tell us that it's more severe than we think, okay? And I think this is going to change the way we grade PDR. I don't know if I want to go through this. Basically, this was a very complicated study that looked at compared Lucentis versus Eylea versus Avastin in macular edema due to CRVO, the cost effectiveness and the non-inferiority. Which is better? Is it worth it? So I'm not going to go into the whole detail, but basically the bottom line is that bevacizumab, Avastin, was not non-inferior to ranibizumab. Okay? It was not non-inferior. It could be inferior to ranibizumab. Aflibercept was not inferior to ranibizumab, but it was not better. All right? Bevacizumab was not inferior to aflibercept. And basically, the bottom line is that bevacizumab, in some cases, may be as good as ranibizumab and aflibercept, but sometimes it actually may not be at all. It could actually be worse than ranibizumab and aflibercept, okay? And that the bottom line is that there is a low level of confidence for recommending Avastin treatment as equivalent to ranibizumab or aflibercept over 2 years in CRVO. Very quickly and exciting, this is a study on using stem cells for retinitis pigmentosa under the retina. It's, again, a phase 1 and 2A study. It's a study that primarily looks at safety, but some efficacy. These are stem cells taken from fetal retina. They are differentiated into retinal cells. They are cryopreserved and put on a shelf. They do not cause any according to them, immune responses. They are delivered directly to the subretinal space. You can order them like you order an amniotic membrane, basically. And it doesn't matter what type of RP people have. It doesn't matter what gene mutation it has, because it is agnostic to the genetic type of disease. Now, they did they already enrolled 12 patients in a phase 1 study looking at the safety, and then another 10 patients in the phase 2 clinical trial. All right, and they inject 1 million cells into the macula, under the macula, and they look at the primary endpoint, which is the change in vision. So it's primarily vision. So 22 subjects in total, and the dose escalation here was generally well tolerated, and there was no evidence of inflammation. And there were 2 side effects, but they were related to the procedure, but not to the drug. And basically, they're saying that patients have improved vision. Now, we know that RPE is primarily a peripheral rod disease, but with time, it affects the cones because you have atrophy of the retina, increase in oxygen tension level in the retina, and that the too much oxygen creates a state in which the cones will not survive. So with time, the cones act. So basically, I think the reason they're doing this is to try to preserve whatever is preservable in the macula to start in RP. But this is not the end of the story. Just telling you that progress is happening, and it's happening fast in terms of therapy for genetic diseases. And finally, there's also a drug that Peter Camposciaro from Hopkins is trying for retinitis pigmentosa to preserve the cones by giving oral N-acetylcysteine, which is a potent antioxidant, and that seems to be also working. So we'll see how that goes. Thank you very much for everything. I think Dr. Diego, you want to say something, right? And if you are interested, we can share some videos, but I don't know if we have time. I think I went.
I think we are close to the end of the hour, so I need also 15 minutes. So probably what we can do is to we can discuss, we can set another ground round for the remaining topics for the oculoplastic and everything. It's only 6 minutes now. And you can probably now, if they are ready, we can share some video. So you conclude your retina update. And next time we'll set up for oculoplastic and PITS. I think it would be better. Okay. Are you ready with the videos? I think.
I'm not sure if you which videos you want. I thought initially that we were going to have a little bit of time because some speakers are unable to give their talks. But we can access the AA website and look at some videos if you want. But there's so much to say, so I'll put it on. There's a video of a bag in the lens implantation by Klaus Eckardt, if you're interested. And there. Okay, and there's also a video presentation on drops for presbyopia. Which would interest you more? Why don't we have a show of hands? I mean, there's so much to do, but there's one on presbyopia, drops using for presbyopia instead of glasses. That was the show of hands. Who wants to see the drops for presbyopia? Show of hands, really high, I really can't see. And who would prefer to see the surgery of implanting a lens, an IOL, implanting the bag into the IOL rather than lens into the bag? Okay, there's more on that. Okay, I'll do that. Okay, all right, sure. Let's do that. So, I have to remember my password. Let me see. Oh, you cannot see this? بلدنا اللي موجود هنا باين؟ تمام. Okay. Yes. If there are questions? Yeah.
Although it's not my field, I was impressed that now the evidence and the need in emergency to assess the patient with central artery occlusion. So I would have any question or comment about the floor, and how do you think that is something? How does it work? Because it's not my field now in KKESH, and how my question to you is, because of these guidelines, and now we have to move our step based on the evidence-based medicine. Because of these, this came out recently. What do you think? How far and how long it would take to get in this process properly? I mean, to assess the patient and immediately refer to another hospital. Do you think there is the need to take action very soon for those patients?
I think the evidence is in the literature already that a lot of people have these silent infarcts and we don't know about them, and they're asymptomatic. And they can go into a myocardial infarction or a much more severe stroke in the days to come. So I think it is like a call for help, the central retinal artery occlusion. So the evidence is there. Does the evidence apply to our population? Probably. I mean, the evidence is basically based on Western literature, essentially. But, I would think that it would apply. And I think what we should develop is a mechanism by which we have a collaboration with a well-defined, known stroke center in maybe University Hospital, or maybe at King Faisal Hospital, or at one of the Ministry of Health hospitals that we trust, in which we immediately can refer those patients to them for immediate investigation. I think it should be done, because it would be neglect if we know this and we do not do this for people who have central retinal artery occlusion. I think we're not doing them a service.
Yeah, because I mean, I was wondering in Europe, it's like United States. There is also medical legal problem. So I was just thinking, if you see a patient in this condition and you let them go home, and after 24 hours or within short time, he had any stroke. If you are in North America, particularly if you are in US, or if you are in Europe too, particularly in Italy, you can be lawsuit immediately. True. And so that's the reason I raised this question.
Yeah, no, it's a very valid point. But even beyond what's lawful, I think our consciousness, now that we know, we should not, we should do our best to strive to help. Maybe people are not going to go into a lawsuit immediately here, but with time, people are going to recognize this. But we know it, and I'm sharing it here because I wasn't so much aware of this. I know that there is a higher incidence of stroke in people who have central retinal artery occlusion. This is why we do an echo, transesophageal echo. This is why we look, for embolic sources. We do that, but to do it with that sense of urgency has not yet gone into my brain until I heard it with that. I said, we definitely should. If I cannot save the eye, at least I want to save life, if I can, So.
Actually, my question is, yes. The stroke, in this country, do we have like stroke teams like that we can refer the patients? That's the issue, I think.
We need to know. I do not know which is the closest and the best stroke center. I honestly don't know. Is it the military hospital? Is it the university hospital? Or maybe Dr. Zahrani can tell me.
I think King Fahd Medical City, they have a huge neuroscience center, but we have to have an agreement with them. We have to
Exactly.
sit with them and discuss this issue with them. I think it's
Exactly.
just sending the patient from here, he might be lost in the
No,
system.
of course,
So we have
of course.
to have an
I think we
agreement.
need to have a protocol. We need to have
Yeah.
a protocol for this. I agree, absolutely.
I have 2 points here. One comments regarding the lidocaine gel injections.
Yes, sir.
I almost always use it in my patients.
Okay.
I find it, yeah.
We'll look at your incidences. Okay.
I find it very helpful for them from pain
Yes.
point of view. But what I usually do, I usually put 1 drop of pinoxynate or tetracaine, and then I put 1 drop of bofidone before I put the gel.
Exactly. So
this-
you
they-
create
yeah,
this
alhamdulillah, I didn't get any
sandwich.
risk of-
Yes.
Yeah.
Yes.
The surgery, and what's the how frequent they inject these patients, because they are now vitrectomized patients. Did they cut off the injection intervals or not?
That is a very interesting point. There were some people, as you can tell, like 75% were injection free, so that automatically says that 25% were not. But yes, they did require more injections, but whether the injection frequency was decreased versus increased, that was not addressed. But they're trying to do this via the choroid without the need of vitrectomy. So in the future, they're going to try to do this gene therapy with a suprachoroidal
Suprachoroidal space?
Yeah,
No,
yeah.
okay.
Subchoroidal space. Yeah, just between the choroid and the retina. That's what they want to. Well, space, whatever space. Yes,
How-
where you go in the suprachoroidal space, I guess. Yes.
Like a suprachoroidal
Yeah.
injection of triamcinolone in US
Yes, similar to that. Yes. Yeah. Exactly. All right. Thank you. But that was yes, Saleh. Yes. Sure.
Gel part of this, because I never used it, and I gel because the problem of the pain is not in the surface; it is mainly in the choroid, and none of our drugs will penetrate. And I think talking to the patient, telling them that you will feel that prick, I think this is the way to go. Because some of my colleagues, they leave the gel for a while, and true that if you are putting it iodine before the gel, probably you'll have the surface cleaned up.
Yeah.
But I don't think there is a role for the gel, because we have the drops, they will do the job on the surface, and since none of them will penetrate, probably we are treating ourselves rather than the patient. And another thing for the central retinal artery.
The central artery occlusion? Or?
Yes.
Yeah. Yes.
Anybody doing like now they do for the stroke embolectomy to remove that, like the one we are doing for intraretinal treatment for retinoblastoma, for example. Anybody is doing it if it is caught early?
Well, this is what the TPA, not the embolectomy, but what has been described is the TPA injection via an angio, going via catheter and injecting it into the central retinal artery, or actually into the ophthalmic artery. Apparently, it's not efficacious, and apparently an article came out on that, and I have not seen it, but now I know, in ophthalmology in 2015, and apparently there is no basis for it.
Even
it doesn't work.
Stroke, the TPA was not found as good, but now the routine is to do embolectomy, and now there is a team in Riyadh for embolectomy for the stroke.
Right. Yes.
And this works.
Yes.
This works if it is caught early.
Yes. Yes. For the central retinal artery, it's hard. I mean, you have to go surgically, right?
You need catheterization.
Yeah.
Same as for the stroke.
I don't know of any team that is doing it, Dr. Amro. It'll be interesting to look into this. I don't know if any team is doing this, but it will be a challenging procedure. I think probably better with robots.
Yeah, but
All right.
now they are doing it with the human intra-arterial.
For the chemotherapy for the retinoblastoma. Yes. Yeah. But it doesn't go to where the embolus is. The intra-arterial is basically very close to the origin of the artery you inject, right? But it doesn't need the maneuver of going into the artery and doing the embolus removal. I think it's more tricky, especially if the embolus has traveled a little bit downstream, in the retina. I think it's trickier.
Yeah, we are talking about central retinal artery,
yeah.
where mostly it is in the
Close to the lamina. Yeah.
close.
Right. Do we have?
I think it's time is over. I think we have a weekly quiz
Okay.
now.
Oh, yes, that's right. I forgot.
Yeah,
Sure.
yeah, okay.
In the future, inshallah.
Okay, okay. So
All right.
we might have, because it was so interesting and we also
Thank
opened
you.
the floor of discussion,
Thank you.
I would thank you, Dr. Sosa Noilati. She gave a
problem.
very, very good
Thank you.
presentation.
Thank you.
And yes, we will proceed with the next speaker for the weekly quiz, and hopefully we will have a second part of update about the new insights of the American Academy.
شكرا. هذا فين؟ هذا أمام. This forward. Or I'll use this. Good afternoon, everybody. Okay, we'll start with the first case. What's the diagnosis and what therapeutic modalities are available for this condition? Diagnosis and therapeutic modalities. Question number 2. Describe the clinical findings and what is the most likely diagnosis and what other parts of the exam you would like to do in this patient. The clinical findings, most likely diagnosis, and what other parts of the exam you would like to do for such a patient. Question number 3. What is the diagnosis? And what are the indications for surgical removals? Question number 4. What's the diagnosis? And when do you decide to do surgery for such a patient? Last question. What is the very obvious sign that you see here and the differential diagnosis? And if you can kindly collect the answers So we can go back. Okay. Next question, the clinical findings, most likely diagnosis, and what else you want to examine in such a patient. Question 3, diagnosis, and when do you go ahead and do surgery? Question 4, what's the diagnosis, and again, when do you do surgery? Last question, what is the most obvious sign here? And mention few differential diagnoses, 5 at least, 5 differential diagnoses. Abshir. If you can kindly collect the papers. Yes. In similar cases, not necessarily in this case. When you mention the diagnosis, you mention, when do you do surgery in this diagnosis? Not necessarily in this patient. And please, thank you very much. Please collect the papers. Thanks a lot. Can somebody from the male side also collect the papers? Thank you. Thank you very much. الدكتور جزاك الله خير شكرا. Thank you. We're going to answer the quiz directly, so please, don't go away. Yeah, and then we'll follow with the case presentation. We'll have a break after that. Shukran. Okay. The case presentation, who wants to present first? There are 4 of you. Case presentation, who's prepared? تفضل دكتور. Yes. Yeah. Go ahead. Yeah.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good afternoon, everyone. My name is Rakan Granius. I'm a third year KKESH program resident. Today I would like to talk briefly about a case of VKC with shield ulcer. First of all, to start with history, he is a 7-year-old medically free child with the history of on and off activity of VKC, both eyes. States post-supratarsal kinologue injection in both eyes in December 2018. He was on cyclosporine lubrication and Petaday. He presented in our ER a few months back complaining of photophobia since 1 month, and on examination left eye was unremarkable during the exam. Right eye with vision of 20/80 and IOP was within normal. A giant papillary reaction with mild ptosis in the lids with 2+ injection of the conjunctiva. Cornea shows superior shield ulcer 4x4 millimeter with the paracentral scar with no infiltrates. AC was quite in both eyes. The impression was active VKC in the right eye with plaque and shield ulcer. And the plan was to admit the patient and start him on Vigamox, cyclosporine, and Pritfort, T-taper, and Carbomer. Then examination under anesthesia with a possible scraping of the plaque. This is a video clip passed kindly by Dr. Abdullah Awayed, fellow at that time, fellow on call. So after general anesthesia and usual cleaning and drape of the patient, he started to do the scraping by Wixel. Some part was successfully removed and the other part was removed by forceps, as we can see here. Then the other parts was or were removed by 64 corneal blade. Then he put a BCL. Then the patient was followed regularly on BCL with topical antibiotic and lubrication. CD was completely healed after 10 days from the admission or from the third day of surgery till he discharged home. So it's a VKC or vernal keratoconjunctivitis is atopic condition of the external ocular surface, frequently bilateral and asymmetric in nature, affecting young children of age less than 18 years. Males usually being more affected than females, but this difference decreases with increasing age. VKC considered as immediate hypersensitivity reaction, and approximately 50% of patients with VKC have no family or personal history of atopy, and large proportion have negative results in the standard allergy diagnostic test, confirming that it's not solely IgE mediated. Additional attention has been given to the CD40 helper 2 driven type 4 hypersensitivity immunomodulators such as interleukin 4, 5 and basic fibroblast growth factor. In history, VKC was firstly described by Arlett on the 1846, describing 3 cases. In 1899 was described by Trantas dots, but before that Horner described it, hence the name of Horner Trantas dots. 1908, Gabrielides identified eosinophils in the conjunctival secretion as well in the peripheral blood of VKC patients. And in 1910, Trantas characterized the spectrum of corneal changes seen in VKC. It is more common in hot and dry climates countries, most likely to be present in West Africa and Mediterranean basin. The majority of VKC occurs between the ages of 5 to 25 and the peak between 10 to 12, and it presents as early as 5 months old. While VKC is atypically or typically seasonally recurrent, hence the name, 23% of patients may have perennial form. And the incidence of shield ulcers in some studies found to be between 3 to 20% of them. We have 3 types. We have the palpebral type, primarily involving the upper tarsal conjunctiva, and the limbal type typically affects Black and Asian patients, and mixed type of both of them. Another classification called into grades, which grade 0 absent symptoms, grade 1 with mild symptom but no corneal involvement, grade 2 also no corneal involvement but with moderate symptoms, grade 3 which is severe symptoms of photophobia and a cornea with mild to moderate SPKs or with diffuse SPKs or corneal ulcers. Symptoms usually itching, photophobia, foreign body sensation, mucus discharge called dropy, blepharospasm, and blurring of vision. Photophobia can be quite severe, render slit lamp exam challenging if not altogether impossible. And the signs here, starting from externally, a reactive ptosis mostly present in a palpebral type due to obvious tarsal deformities and mass-like effects, usually present asymmetrical. We have three types. The signs as conjunctival signs include diffuse conjunctival injection and upper tarsal giant papillae of more than 1 millimeter in diameter. Additionally, these giant papillae can sometimes be seen near the limbus, and while relatively uncommon, symboliform formation and conjunctival fibrosis can occur. We have limbal signs as well, include thickened and opacification of the limbal conjunctiva, with as well as gelatinous appearing and sometimes confluent limbal papillae. Perilimbal hornatrantus dots, as we know it. Limbal disease can result in a limbal stem cell deficiency leading to pannus formation and corneal neovascularization. Corneal signs vary according to the severity of the disease process. Punctate epithelial erosions can coalesce into macro erosions of the epithelium, and the plaques containing fibrin and mucus can accumulate into macro erosion forming shield ulcers. Corneal neovascularization can follow, and resolution can leave a characteristic ring-like scar, as we can see in the upper right picture. Waxing and waning gray-like gray-white lipid deposition in the palpebra. Superficial stroma can occur and is known as pseudogerontoxin. Keratoconus can happen from frequent rubbing of the eyes. Management of VKC doesn't differ substantially from AKC, but the latter is somewhat more recalcitrant. The VKC of for VKC the followings are helpful steps of management. We start by allergen avoidance, if possible. Cool compresses may be helpful, and lid hygiene should be used for associated staphylococcal blepharitis with moisturizing cream to be applied in dry fissured skin. Topical medication, we have dual-acting agents like olopatadine to be used, have been successfully treated some cases. Topical steroids are very effective, particularly in quietening the exacerbation, but we know the long term of them with the profile of side effects like cataract and glaucoma and others. Loteprednol, an agent with less of an effect on intraocular pressure, has been found to be the best choice of topical corticosteroids. And topical acetylcysteine 5 to 10% has been used to reduce the mucus adherence on the cornea during exacerbation. With their ability to inhibit T cell activation, interest in the efficacy of cyclosporine A and tacrolimus has emerged. Significant improvement has been reported using 2% of formulation of cyclosporine. Lower strength formulation as well of cyclosporine, 0.05%, appear to be effective but much expensive. Use of topical tacrolimus, 0.1%, has shown promise with lesser side effects. This diagram from American Academy showing if you have a patient with micropapillae with no corneal changes, you can just directly use mast cell stabilizers and antihistamine as well as with lubrication. If you have them with mucus accumulation, micropapillae, and corneal vascularization, topical corticosteroids are useful with mild or few percent of topical immunomodulating agents to be used. If you have micropapillae with the previous mentioned signs as well as shield ulcer, persistent severe inflammation, you will use higher percentage of immunomodulating agents. The surgical management, it's rare to be used in VKC patients, but some require them. Surgical removal of corneal plaque, as in our patient, is recommended only in severe persisting cases to allow corneal re-epithelialization. We did not do it in our case but we might do it later if the disease is persistent. Giant papillae excision with the intraoperative mitomycin C to be considered with severe mechanical ptosis, and large coarse papillae with corneal changes. Supratarsal steroid injection, as we did in our patient, may be considered in severe recalcitrant cases. This is one of the studies showing the useful management with AMT with the promising results. This case presented in November 5th, 1999, after 7 days with complete resolution. So in the prognosis, the nature of history of VKC is one of resolution, specifically with arrival of puberty. Specifically with the arrival of puberty, there is a relative lack of information on long-term history of the disease. In one study with a median follow-up period of 47 months, only 29% of patients had complete recovery. Some improvement in symptoms was seen in 35%. 31% reported no clinical changes, and 2% had worsening symptoms. However, further follow-up may not be available because of the high probability of disease resolution with time. VKC is a disease of myriad presentations, some of which can generate long-term sequelae. Symptoms can be quite bothersome, and untreated disease can be rather severe. Therefore, appropriate treatment can be site changes. I would like to thank Dr. Abdulaziz for providing me the useful hints about the management of the disease, and a special thank to Dr. Abdullah Al-Uwaid for providing me the case and the video. Thank you so much.
Assalamu alaikum. I'm Manar Al-Jibreen. I'm a second-year resident in KKESH program. Today I'll be presenting a case of bilateral spontaneous hyphema, and I'll be talking briefly about spontaneous hyphema in a pediatric age group. My presentation was supervised by Dr. Abdulaziz Awad. So I will start first with the case. She was a 3-month-old female who was brought to emergency department by her parents as they noticed blood in her eyes. The blood was noticed in both eyes 3 weeks prior to presentation. It was noticed first in the right eye, 1 week later the left eye. There was no history of trauma, and there was no history of change in behavior or activity. She was a full-term baby, normal vaginal delivery, with no NICU admissions. There was no family history of sickle cell anemia, glaucoma, or poor vision since childhood. Now, the examination that was done upon arrival in ER, the VA cannot be assessed at that time. IOP was digitally high, 30s, and the slit lamp examination of both eyes showed mildly injected conjunctiva, cloudy cornea in both eyes. AC was deep with high FEMA inferiorly in the right eye, and scattered bleeding spots on the iris of the left eye. There was a yellowish lesion at pupillary plane of both eyes that was covering the pupil with no further details. In general examination, she had multiple skin lesions, elevated papules. So before going through the case and the investigations and the hospital course, I would like to talk briefly first about spontaneous hyphema in childhood and the differential diagnosis. Now, spontaneous hyphema is not a common presentation in general. And in pediatrics, if we compare pediatrics and adults, it will be different in the differential diagnosis, or it's like the priority in differential diagnosis will be different. In pediatric, the top differential diagnosis that you should be thinking about in a patient who will present with spontaneous hyphema is retinoblastoma. Now I'll be talking about the unilateral. The bilateral, I'll be talking about it at the end of the presentation. Retinoblastoma, they can present with spontaneous or traumatic hyphema. Although it is considered as an atypical presentation of retinoblastoma, every effort should be done to exclude the tumor in all cases of hyphema. The reason behind that, it's hyphema is a high-risk clinical predictor of retinoblastoma. If you have hyphema, it means that the tumor is advanced and it has already extended to the anterior chamber. And one of the reported cases actually was surprisingly not because of the tumor in that eye, the retinoblastoma of that eye. It was because of it was a metastasis from the other eye. The tumor, the retinoblastoma, was in the other eye, and then it was inoculated and managed, and the patient presented with hyphema in the good eye. No retinoblastoma was detected in that eye. It was only metastasis. So you have to be careful when you evaluate a patient with hyphema. The first thing that you should exclude retinoblastoma. Now, the second differential is shaken baby syndrome. I know that shaken baby syndrome is considered as traumatic hyphema. However, parents will not tell you that there was a trauma usually. It's physical abuse, so they will present to you as a spontaneous hyphema, or they will be referred from pediatrician or any social worker or anything. So shaken baby syndrome, they will have signs of periorbital trauma, lid edema, or anterior segment findings, hyphema, or posterior segment findings, vitreous hemorrhage. You will also find intracranial bleeding, subdural hemorrhage, and bruises. So if you suspect shaken baby syndrome, you have to look for any other signs of physical abuse. The other differentials, I put them all in the same slide because they share the pathophysiology. Retinoschisis, it is an unusual cause of spontaneous hyphema. However, it was reported in a child who had repeated bleeding. It was an unseeing eye. He had repeated bleeding and pain, so it was inoculated. Then they found that there was a giant schisis, and they thought that it was the cause of the hyphema. It was thought also to be originating from the blood vessels that were anterior of the anterior retrolental leaf of the schisis. The other also differential is retrolental fibroplasia, which is usually found in low birth weight babies or retinopathy of prematurity. The third differential also here that share the same pathophysiology is persistent hyperplastic primary vitreous. Now, PHPV also, they will have different degree of vasculature, which will lead to bleeding either anteriorly or posteriorly. Now, juvenile xanthogranuloma is considered as the most common cause of spontaneous hyphema in children. It is a benign histocytic proliferation, and it's characterized by the presence of toton giant cells. As you can see here, the cells are clear. Majority of patients, they will present like 75%, they will have only solitary cutaneous lesion. It will be a discrete round firm papule, which is brown, red, yellow in color, size varying from 1 to 20 mm. However, if we will talk about extracutaneous involvement in juvenile xanthogranuloma, the eyes will be the most commonly involved, with a prevalence ranging from 0.3 to 10%. If we'll talk about the ocular sites, iris will be the most commonly involved in juvenile xanthogranuloma, followed by the conjunctiva. So in the iris, it will be a localized yellowish vascularized lesion. It can be flat and it can be elevated. It is usually unilateral, and it will lead to spontaneous hyphema up to 90% of the cases. The problem will not be the hyphema, actually. It will be the secondary glaucoma resulting from the hyphema. As you can see here, the lesion, the iris, some of the mothers will come they will present telling you that there is different in the color of the eye. So they might come earlier than the hyphema. So other differentials, like blood coagulopathy it is rarely to cause spontaneous hyphema, but it's mentioned. Inflammation, also iritis, which is not usually the cause in young age group. Going back to our patient was admitted for further investigation, daily observation, and IOP control. B-scan was done to the patient, and it showed only mild vitreous opacities with normal posterior pole. UBM was done, which showed 360-degree narrow angles, anterior hyphema, and organized opacity detected within the anterior cavity of both eyes. Ciliary body was rotated anteriorly with no further details. MRI was done to exclude retinoblastoma or any finding retinoblastoma, which was was not there. Skin biopsy was done by oculoplastic, which was suggestive of juvenile xanthogranuloma. So our patient was diagnosed as juvenile xanthogranuloma, and it was an unusual presentation of juvenile xanthogranuloma because it was bilateral spontaneous hyphema. She presented actually multiple times with rebleeding, uncontrolled IUP. Finally, they did peribulbar steroid, and still the IUP is not managed. If we will talk about juvenile xanthogranuloma hyphema, the management should be directed as usual in hyphema. You have to prevent rebleeding, prevent amblyopia, and manage secondary glaucoma. A few cases were managed by steroid, as it was done in our case. However, it was not the management guidelines. It's not it is not well formed or well known as like steroid. So you have to go step by step and check the patient's IUP all the time. Bilateral hyphema, we started the case as bilateral hyphema. It is a rare presentation in general. In pediatric age group, approximately only 5 reported cases that I could find were reported as juvenile xanthogranuloma and were having bilateral hyphema. Adults, usually there are a few cases reported also, but they will be related to medications. They will have a lot of systemic diseases. Like one patient had aplastic anemia, the other was on anticoagulants. So it is usually related in adults to systemic conditions. However, in pediatric, it was usually related to juvenile xanthogranuloma. So take-home message, although spontaneous hyphema is uncommon, serious causes should be carefully investigated. This patient can, as Dr. Mesfer today mentioned, they can present, you can save their life by only investigating. So spontaneous hyphema can be a finding of retinoblastoma. Thank you. Any questions?
Hello, afternoon. Before I start, I would like to thank Dr. Abdelaziz Awad for his kind review and the supervision. My case is about a 19-month-old boy. He's medically and surgically free. He's a full-term, normal delivery, normal growth and development, not on any systemic or ocular medications. He has negative family history of any ocular or systemic diseases. The family brought the child to the emergency room, complaining that the child cannot move his left eye to the left side for 2 days, following a head trauma, falling down, unwitnessed. They said there is nothing changed about the status of the child. He's playful, no broken bones, nothing else. Just the only complaint is the eye. So the examination, for the external inspection, the child is normal, no syndromatic changes, no broken bones, no bruises. There is no obvious head tilt or face turn. The vision is a central, steady maintained in both eyes. Cyclorefraction is +3, both eyes. There is deviation in the left eye, esotropia of 25 prism diopters. The ocular examination, anterior segment and posterior pole is within normal limit. This is a 9-gaze photo of the child. As you can see, the left eye cannot abduct, and the up gaze, low gaze, and the central gaze. So the child cannot pass the midline on verges and adductions. Differential diagnosis, the top is 6-nerve palsy. We have other differential, congenital and acquired DT, Duane syndrome, myositis, and blowout fracture with entrapment of the medial rectus muscle. So we did imaging for the child, for the brain and the orbit, and everything, alhamdulillah, was found to be normal, and no evidence of 6-nerve injury was found also. So the decision was to observe the child and to give a follow-up. Lastly seen yesterday, the child was uncooperative to do full exam, but the family noticed improvement. The ET was found less than 20 prism diopter. As we mentioned before, it was 25. A 2-month follow-up is also given, and decision of observation only is the choice. So, sixth nerve palsy, as you know, the sixth nerve is the abducent nerve. It controls the lateral rectus muscle. Any injury to that nerve can cause the abduction deficit in the affected eye. Deviation in this injury is constant, all the time present, and it's usually greater at distance than at near. Multiple etiologies, and you can divide causes into either congenital or acquired. Congenital can be due to trauma, can be due to neurological diseases like hydrocephalus or cerebral palsy. Acquired can be due to trauma, benign recurrent sixth nerve palsy after viral infection, elevated or low intracranial pressure like shunt failure, pontine gliomas and other intracranial tumors like medulloblastoma, infections like meningitis and Lyme disease. The approach, as we mentioned previously, history, full exam, and imaging. And lastly, we do the management. We didn't talk about it, so I'll just visit it briefly. The first step is to rule out life-threatening conditions, like brain injuries. This is the main thing. After that, we can give the patient a chance for spontaneous recovery. So usually this takes to 6 months without an intervention. If there is no recovery during that time, we can determine the pathology. Either we can have a complete palsy or medial rectus contracture, which is a partial palsy. This evaluation can be done by 3 means. The first one is the saccadic velocity. If the child can do saccade, fast saccade, and sudden stop, that means the sixth nerve has some potential. So it's a partial, and it's due to medial rectus contraction more than the sixth nerve. But if there is no saccadic movement, it means that there is a complete paralysis and palsy of the optic nerve. We can do also force generation test and force reduction test in the OR, with a child and of adult in the clinic. Trial of Botox injection to the medial rectus to paralyze it. If we suspect a partial palsy, can be done. So the intervention, surgical intervention, after we decided the cause, if it's complete, we can do a transposition procedure of the vertical recti muscles, superior, either superior or both, superior and inferior, plus and minus weakening of the ipsilateral medial rectus. If it's partial, we can do R&R of the affected eye. I brought just a study to show us how to manage a residual AT in traumatic sixth nerve palsy. So this patient had a trauma 8 years before the presentation. Imaging was done and examination done, brain and the eye within normal limit. The patient had a previous surgery to this presentation, previous surgery of R&R. They did left medial rectus resection of 7.5 millimeter and left rectus muscle resection of 9 millimeters. Upon the presentation, the patient still have 52 prism diopters, left residual to esotropia, first turn to the left side, diplopia in primary position and on the left gaze, -4 limitation in abduction on the left eye. So surgical exploration was done. Left medial rectus insertion was found to be 13 millimeter 0.5 from limbus, and force reduction test was strongly positive. So the surgical intervention they chose is to do ipsilateral re-resection of the lateral rectus of 5 millimeter and more, combined with 4 units of botulinum toxin to the medial rectus to release the contraction. The 6-month follow-up, the patient improved, 12 prism diopter left ET, -3 limited abduction. Patient still having diplopia in the primary position, but single vision was achieved with 10 prism diopter spectacles. Other options to redo resection and resection surgery and to do vertical muscle transposition. And why I brought this study is just to mention or stress on 2 points. Usually the initial treatment success of chronic non-resolving sixth nerve palsy is low. It can reach to 10% only, and 2 or more procedures or surgeries needed to resolve the issue. The other thing is the transposition procedures. We should consider this as a sometimes dangerous and risky in previously operated eyes. The risk is to avoid, or the risk of doing transposition procedure in operated eye is to develop anterior segment ischemia. So we need to avoid that. So lastly, final success rate in traumatic sixth nerve palsy is 59%. 45% of traumatic cases required more than one surgery. 32% of patients with chronic sixth nerve due to different etiologies needed also a second intervention. Thank you so much.
Assalamu alaikum. This is Lamia Al-Hiji, second year resident, KKESH program. I would present one of the cases. It's an unusual case, not just because of its presentation, but also because of its unfortunate sequence of presentation. This is a 4-year-old boy, medically free, presented in KKESH program in 2015. He was referred from another hospital as a case of left eye cataract for management. The mother mentioned poor vision since 6 months in the left eye with pain and redness in the left eye for 1 week. There was no history of trauma and no history of surgeries. So that time they ordered P scan to the left eye and they did a complete ocular examination. It showed, right eye showed normal, left eye there was leukocoria, lids and lashes were within normal, there was conjunctival injection with mild corneal haze, AC was deep, but there was NVIs noted, also there was a nuclear cataract. There was no view to the fundus, so they did B-scan. B-scan reported as the follows. It was dense, the report mentioned dense vitreous opacities, total wide funnel shaped RD, and dense subretinal opacity. Macula was off. Based on the B-scan, pediatric team was consulted. Their impression after the examination that it's a left total funnel RD with neovascular glaucoma of the left eye. The family were consulted about the poor visual outcome of doing retinal surgery for this patient, as it's an inoperable RD. So the father that time refused to do any surgical intervention if there is now a good vision guaranteed. So upon another follow-up, the child presented. It was a 3 months later follow-up. The eye was ophthalmic, there was lid swelling, there was conjunctival injection, band keratopathy, hyphema, and negative red reflex. There was a progression. Upon that time, nothing was done, only another regular follow-up was given. Then the child presented later with a medical report seen in another hospital at King Faisal Specialist Hospital that was admitted as a case of metastasizing retinoblastoma post first chemotherapy. The globe was disfigured, and that was the MRI report. It showed orbital extension and included the bone, the orbit. Also, there was CSF extension. So it was at that time oculoplastic were consulted, and at what time they said that it's a metastasizing retinoblastoma, we would continue chemotherapy. Last time seen, the patient came with a MRI that is repeated. He had received 3 doses of chemotherapy, but it was an advanced retinoblastoma case with leptomeningeal bone marrow involvement. So that time enucleation wouldn't do anything to save the patient. Unfortunately, the patient passed away. And for that, I would like to emphasize about a few things. That if a patient came with retinal detachment, does not have any previous history of any trauma or anything that would make us label that this is the cause of retinal detachment. And in a young boy, it is not so common to see pediatrics with retinal detachment. Also, the NVIs, you should have raise a suspicion of a posterior pole pathology, specifically intraocular tumors. So I went through a few articles about retinoblastoma, and one of the articles, it was a very interesting article about what could be the presentation in retinoblastoma in India hospital. They reviewed 392 cases, and even though leukocoria is the most common presentation of retinoblastoma, but there are some patients who came with atypical presentation, including endophthalmitis, like as you see, secondary glaucoma, corneal edema, orbital cellulitis, cataract, iris neovascularization. Another study done here in KKESH about the retinoblastoma in older children, and I wanted to highlight that older children would present with atypical presentation, such as uveitis, cellulitis, and or trauma. And 47% of these patients, they had a clinical and histopathological atypical features. Another study done also in KKESH, they reviewed 292 patients with orbital cellulitis associated retinoblastoma. 14 patients had retinoblastoma with associated cellulitis. They have enucleated 12 eyes, and they found diffuse necrotic, a poor differentiated retinoblastoma. Furthermore, I found an interesting article talking about the clinical spectrum of diffuse infiltrating retinoblastoma. There was 32 patients of 1,507 patients who had retinoblastoma. Only 2% they presented with the diffuse infiltrating retinoblastoma. The mean age of their diagnosis was 4 years of age, such as our patient. And the referring diagnosis all included retinoblastoma and others like uveitis and Coats and the trauma. What I found it interesting here, the anterior segment finding in these patients, they were just like our patient. They had either conjunctival edema, injection, iris neovascularization, and such, and even so. And these are some of their patients who were presented and reviewed. As you can see, the patient A presented with pseudohypopion, just like our subspecialty lecture today. Patient could present with pseudohypopion. The second case was retinoblastoma with lack of calcification in P-scan. But when they enucleated the eye, they found a tumor. The last patient had an AC cells indicating a tumor. When they did the CT scan, they found calcification. So just to overview that, I wanted to highlight about the importance of to maintain high index of suspicions of retinoblastoma in all children with unusual ocular disease in which the diagnosis is unclear. And always to examine the other eye, rule out any other pathology. And if the B-scan findings were not convincing, we have to repeat and or do further investigation if it's indicated. Finally, do appropriate consultation. I would like to thank Dr. Salih al-Misfir because he's the one who mentioned the importance of presenting such a case to make us more careful when we do examination for such patient, because as an ophthalmologist we could not just save a sight, we could save a life. Thank you so much. You would show the quiz answers. أتوقع أنها هنا.
السلام عليكم. نحل سوا الأسئلة. أول سؤال كان what is the diagnosis and what are the therapeutic options available for capillary hemangioma? Anyone can answer? أيوة. Okay. Okay. Describe the above clinical finding and what is the most likely diagnosis? أيوة. Okay. Okay. So corneal diameter, IOP, any anterior segment abnormality to see causes of secondary glaucoma, posterior pole exam, including disc assessment and cycloplegic refraction. What is the diagnosis? And what are the indication of surgical removal? جواب جماعي يعني. Okay. Okay. When to remove? Okay. Okay. If the size is more than 3 millimeter and if it interferes with refraction or fundus examination. What is the diagnosis and what are the indications of surgery? أيوة. طيب. Okay. Okay. So right doing retraction syndrome, it's type 3 because there is limited abduction and adduction. And there is leash phenomena, صح? He's ortho on primary gaze, but we don't know if he has abnormal head position. So abnormal head posture is indication of treatment. Cosmetically unacceptable up or down shoot or severe retraction are all indication. طيب. What is the obvious sign? أيوة. Okay. What are the most important differential diagnoses? Okay. طيب. ما قالها. Okay. طيب صح. Bonus. What is the diagnosis? What systemic association you need to rule out? Okay. Wilms tumor, rule out regular abdominal ultrasound till adolescence. في something يعني every 6 months something يعني read about it. خلاص. Good luck. شيء بسوي هوس الانسرز اي حسين كذا يعني لا اسرع بس عشان مو الحين ارسل لك يلا تبين الصورة ولا دقيقة؟ والله صدقيني